So let's take a quick look at the methods to diagnose pregnancy. So we'll be discussing the clinical signs and symptoms which aid in diagnosis of pregnancy, and also laboratory findings, mainly the beta HCG levels in urine or serum, and also the ultrasound findings in case of suspected pregnancy. So these are the previous year repeats from this topic. Write a short notes on methods of diagnosis of pregnancy. And next question is, a lady comes with 2 months of amenorrhea to the antenatal clinic. How would you diagnose pregnancy in her? Okay, and the third question is, how does the pattern of rise in HCG differ between a normal and abnormal pregnancy? So abnormal pregnancy in the sense we have molar pregnancies in which there is an abnormal rise in HCG levels. And how accurate are most home pregnancy tests? And for this I'll be giving you the statistics taken from the different Williams Obstetrics textbook, latest edition. And what are the most common causes of false positive and false negative pregnancy tests? So we'll be looking into that, and this is the most recent or latest question asked in 2018. So when it comes to clinical signs and symptoms of pregnancy, we all know that the secondary amenorrhea, that means cessation of menstruation in a healthy reproductive aged woman who previously had menstrual periods, that she experienced spontaneous, cyclical and predictable menstruation. This is highly suggestive. So one and only highly suggestive factor is amenorrhea. But sometimes what happens, though if the woman is pregnant, even after that, even after pregnancy, some uterine bleeding, okay, it occurs after conception, and this is because of blastocyst implantation. So you are suspecting pregnancy, but there is some uterine bleeding. You have to confirm it with laboratory diagnosis. You cannot just straight away rule out pregnancy in case of uterine bleeding, because it can be because of implantation of the blastocyst. We call it as implantation bleeding. And what are the lower reproductive tract changes which can occur during pregnancy? Very important sign is Chadwick sign. And what do we see in this Chadwick sign? In this, the vaginal mucosa, okay, because of the pelvic congestion, okay, the vaginal mucosa appears dark bluish red. Okay, so congestion of the vaginal mucosa and a dark bluish red appearance is known as Chadwick sign, one of the earliest signs of pregnancy. And cervical mucosa also changes after fertilization. Okay, so we have a follicular phase and luteal phase, right? In the follicular phase, before ovulation, there will be a fern pattern. Okay, the fern pattern will disappear after pregnancy under the influence of progesterone. So there will be some change in the microscopic appearance of cervical mucus after pregnancy. What happens to the uterus? The major changes occurs in the uterus. So during the first few weeks of pregnancy, the uterus grows in the anterior-posterior diameter. Okay, and on bimanual examination, you can feel the doughy nature or elastic nature of the uterus. But at 6 to 8 weeks of the menstrual age, okay, the firm cervix, it contracts with a softer fundus and it is compressible. Okay, so we call this sign as Hagar sign. So to understand it more clearly, we all know that you have a uterus and cervix. Okay, so the change in consistency of the uterus in comparison to the cervix. So cervix is usually hard, okay, whereas the uterine fundus is soft. So we have a compressible area in between. So this is known as Hagar sign. There is a one more sign which is not mentioned here. It is Goodell sign. So they might ask in the exam, what are the clinical signs of early pregnancy? So Goodell sign is an indication of pregnancy, and it is softening of vaginal portion of the cervix. Okay, it is softening of vaginal portion of cervix. So these are the three signs you need to remember. One is Chadwick sign, that is the congestion of the vaginal mucosa. Hagar sign, that is a compressible area between an isthmus and cervix, and also softening of the vaginal portion of the cervix is Goodell sign. So this is isthmic softening is Goodell sign. And by 12 weeks of gestation, the uterine body is globular and reaches an average diameter of 8 centimeters. And what is in later pregnancy, there is another sign called uterine. What is this? Uterine souffle. Okay, this uterine souffle is a sign which is elicited by auscultation. Okay, by using a stethoscope, you can hear a soft blowing sound which is synchronous with the maternal pulse. And what is the reason behind this uterine souffle? It is because of passage of blood through the dilated uterine vessels. Okay, it correlates with the maternal pulse because it is a continuation of the maternal blood flow into the uterus, and during the pregnancy in the later stages there is dilatation of the uterine vessels, and this leads to this sound. This soft blowing sound is known as uterine souffle. So if they ask about clinical signs and symptoms, you can write this. But more importantly, the laboratory diagnosis of pregnancy is more important. What do we do in this? We detect human chorionic gonadotropin in the maternal blood and urine. If given a chance, the most sensitive one is the blood test. But when I say home pregnancy test, logic is simple. The home pregnancy tests are based on a principle that the HCG during pregnancy is excreted through the urine. So the same urine pregnancy test or home pregnancy test or UPT or urinary HCG estimation, all are synonyms. Okay, but the problem with this home pregnancy test is they have high false positive and false negative rates. So the false results are more common with the home based pregnancy test. The most sensitive and specific examination is the serum levels of HCG estimation in the maternal blood. So when I say HCG, what is it? What is HCG and what is its function and why it is important in identifying or diagnosing pregnancy? Let's look at the first structure of human chorionic gonadotropin first. It's a glycoprotein. It contains high carbohydrate in it, and the structure is a heterodimer, and it is composed of both alpha units and beta subunits. Okay, both alpha and beta subunits which are non-covalently linked. When you take alpha subunit, the structure is almost identical to the luteinizing hormone, follicular stimulating hormone, and also the thyroid stimulating hormone. What we measure, okay, most of the measurement, for the measurement aspect, beta subunit is measured because this is structurally distinct from the luteinizing FSH and TSH, so it is easy to detect. So there are what do we do, like how we measure HCG? Antibodies are developed with high specificity for HCG beta subunit. So on the strip test, whatever we do, we have anti-HCG antibodies which are mounted on the strip. By any chance, if there is HCG in the urine, there will be an antigen antibody reaction which will give a visible result. Okay, so that is a principle which is used in commercial immunoassays for measurement of either serum or urinary HCG levels. Why HCG is secreted? See, first thing is the HCG is secreted by syncytial trophoblast. So the HCG, it increases only during the first trimester, and the main function of this human chorionic gonadotropin is it prevents the involution of corpus luteum. See, the main function of corpus luteum, which forms after fertilization, is it secretes progesterone. Okay, for the first few months, in the first trimester, the most important source of progesterone which supports pregnancy is corpus luteum. This corpus luteum is actually maintained. The involution of corpus luteum is prevented by the HCG which is secreted by syncytial trophoblast. So in the early part of the development of placenta, we have cytotrophoblast and syncytial trophoblast. So this syncytial trophoblast secretes HCG, and in turn this HCG will now make sure that the corpus luteum is present till the placenta is fully mature. So once the placenta is fully mature, the function or the work of synthesizing progesterone to support pregnancy is taken over by the mature placenta. Till the time the placenta is matured enough, meanwhile the support comes from this human chorionic gonadotropin, and these levels are helpful in diagnosis of pregnancy in early stages. And how will you assess these levels? There are some sensitive tests wherein you can measure the presence of either maternal HCG in maternal serum or urine by 8 to 9 days after ovulation, very early. Like if the 14th day is the ovulation, if 28th day is the menstruation, there are 14 days in between. But there are some sensitive tests which you can detect just at a stage of 8 to 9 days. Okay. And what is the doubling time of serum beta HCG? The serum beta HCG levels, they double every 1.4 to 2 days. For example, starting with, if the level is 2 international units per ml, in the next 2 days the level will reach 4 international units per ml, and similarly in the next 2 days they reach 8 international. So this is the doubling time of serum HCG concentration. And these serum HCG, they increase from the day of implantation, and the peak is reached at second month. Okay, from starting on the 0 day of implantation, it takes around 60 to 70 days to reach a peak, and thereafter slowly the concentrations decline, and by 16th week, okay, by if I say it's a 12th week, by 16th week, okay, there will be a plateau, the levels they remain. And the sensitivity for the laboratory detection of HCG is as low as 1 milli international units per ml. It's milli international units. And there are some sensitive immunoradiometric assay tests which are available in the market. But the problem with these tests is there are high chances of false results. For example, where do you see a false positive result? HCG synonymous with some of the heterophilic antibodies which are present in the body. Okay, so these heterophilic antibodies might be produced in women who are working very close with animals. Okay, the animal antigens might be having a similar structure to human chorionic gonadotropin. So they might result in a false positive test. Similarly, if for the sake of weight loss, for the sake of pituitary suppression, if a person is receiving an exogenous human chorionic gonadotropic injections, so in that scenario, this HCG cross reacts with the strip test, giving rise a false positive. And the HCG in the body is usually cleared by the kidney. That's the reason elevation of HCG is detected through urinary pregnancy test. But what happens if the kidney fails? Even the normal HCG which should be cleared by the kidney, it retains in the body, leading to a false positive result. Similarly, there is a physiological secretion of pituitary HCG in high concentration, so that also gives a false positive result. And in the body there are some human chorionic gonadotropin producing tumors which might arise from gastrointestinal sites, ovary, bladder or lung. So in all this, we call this as teratomas, which secrete different hormones. And even in hydatidiform and molar pregnancy, though it is not a normal pregnancy, you will still see a false positive result. So what are all the conditions where you see false positive urine pregnancy test? One is presence of heterophilic antibodies. It's not only urine, it applies to the serum pregnancy test also. One is heterophilic antibodies, the other is exogenous HCG injections, and other is renal failure, pituitary physiological secretion of HCG, any HCG producing tumors, and very importantly, the false positives are seen in molar pregnancy. Where do you see false negative? That means the woman is pregnant, but the strip test is showing a negative result. It happens when the levels are not adequately rising. That means either testing it too early. Okay, so you have to wait at least 1 week after missing a period. And in case of irregular menstrual cycles, there might be some false negative test. And if the urine is diluted, the HCG levels are also diluted in that. So that's the reason whenever we advise a urine pregnancy test, we advise women to get it done with the help of a first urine sample in the morning. Okay, and most importantly, nowadays the commercial kits which are available in the market, there are so many companies and we don't know which company is manufacturing the best standard urine pregnancy strips. So that's the reason even the kit error can also be a possibility. Okay, when you're doing a test, there is some timeline mentioned in which only you need to test for it. Like you need to interpret the results within a given time period. Either too early or too late will also lead to an error, giving a false negative result and failure of the strip. And if the strip is not stored properly, there is some temperature which is mentioned on the strip, you have to store it in that temperatures or else the kit will show error. And one more thing is, pregnancy in the ectopic region will also give false negative. So there is an amenorrhea, but still it is a false negative. Always suspect ectopic pregnancy, because in ectopic pregnancy you might not be seeing the same levels of rise in HCG as seen in a normal pregnancy. And if there is any threatened or missed abortion, okay, or an incomplete abortion, low levels or very slow rise in the value occurs, which may not give a positive result though the woman is pregnant. So these are all the false results that can be possible in case of pregnancy test with the help of HCG. As we all know, when I say home-based pregnancy test, that means we are estimating the urine levels of beta HCG. It has so many limitations. For example, there are millions of over-the-counter pregnancy test kits are sold annually, and there was a study conducted by Cole and Associates in 2011, and they have found out that the detection limit, okay, is 12.5 milli-international units per ml. It is required to diagnose almost 95% of pregnancies at the time of missed menses. So there are sensitive tests even detecting less than 1 milli-international per unit. But study says if you want to detect or diagnose pregnancy for sure in 95% of the cases, the tests were positive only once the detectable levels are more than 12.5 milli-international units per ml in the blood or in the urine. And they also note in the urine, sorry, I'm talking about home pregnancy test. They have also noted that only one brand has this degree of sensitivity, and two other brands they gave false positive or invalid results. In fact, with an HCG concentration of 100 milli-international units per ml, clearly positive results were displayed only by 44% of brands. Look at the magnitude of the problem. So it imparts a lot of mental stress on the woman who is taking these tests. If the tests are not proper, see, the biggest problem with this home-based test is the lack of sensitivity of these strep tests. Okay, and as such, only about 15% of pregnancies can be diagnosed at the time of missed menses. And nowadays some manufacturers of new tests, they claim more than 99% accuracy on the day, and some up to 4 days before the expected days of menses. But whatever results I have given you, these are from Williams Obstetrics latest edition. So it says careful analysis. Okay, careful analysis suggests that whatever the advertisements will say, they are often not as sensitive as advertised, because they might be advertising it, but when the studies are conducted, very rarely it has that much of sensitivity. So these are all the issues with home-based pregnancy test. So you can do a urine beta HCG test or serum. Serum is quantitative. You can even look at the levels. It just gives a positive or a negative result. But here you will get a report saying 125 milli-international units per ml is the levels. So you can even track the levels, the rise in levels of HCG also. Why tracking the rise in levels of HCG is important? In the next slide, we'll be discussing a few abnormal pregnancy conditions wherein the rise is so high. So serum beta HCG, yes, it will give you an indication whether a woman is pregnant or not, but it also gives you a quantitative estimation of the levels based on which you can even diagnose the abnormal pregnancy conditions. And as said earlier, the urine tests are less sensitive, serum tests are highly sensitive, and urine tests you should at least wait for 1 week after missed period, and the results are positive only after 14 days. But serum test, you can even test it 1 week before the missed period. That means after ovulation, within 6 to 9 days, if there is a fertilization, you can diagnose it with the help of serum beta HCG test. So what are the levels of HCG? Okay, in normal versus an abnormal pregnancy, how they rise and how they fall. So we will be looking at the statistics here. On an average, the serum beta HCG levels, they double by 2 days, within 2 days. And the levels, as I told you, are peak at 60th to 70th day. That means the peak value is almost 100,000 milli international units per ml, the peak, and the peak is reached at the stage of 10 weeks, and thereafter it plateaus. Thereafter the levels plateau, and the beta HCG level of 1500 to 2000. Okay, when the levels are between 1500 to 2000 milli international units, the pregnancy is now visible with the help of a transvaginal ultrasound. Okay, and if the levels are less than 100, less than 1000, then you have to wait for at least 2 to 3 days for the levels to rise, because too early transvaginal ultrasound will not give you a picture of pregnancy. So there should be an elevation of at least 1500 to 2000 units of beta HCG to detect pregnancy with the help of a transvaginal ultrasound. If the levels are low, better to wait for 2 to 3 days and perform the transvaginal ultrasound then. What about abnormal pregnancy? There are some low values or slow rise in values. It indicates ectopic pregnancy or abortion. High values at the initial stage and very fast rise in the values. Okay, it indicates beta HCG secreting tumors. For example, hydatidform 1 and choriocarcinoma, or even twin pregnancy also will give you high values. And in case of trophoblastic diseases, that molar pregnancies, the levels can reach even up to 40,000 milli international units at an early stage. And even in metastatic cases of these malignant trophoblastic diseases, the serum HCG levels are in between 40,000 to 50,000. Okay, our urinary HCG levels are usually less than for 24 hours. So when the levels are in this range, it indicates a good prognosis. If the levels are crossing more than 50,000 milli international, then this will indicate a bad prognosis. So this is how the levels are different in case of normal pregnancy and in case of abnormal pregnancy, and you should focus mainly on the gestational trophoblastic diseases. And what are the ultrasounding findings in normal pregnancy, either transabdominal or transvaginal? At 5 to 6 weeks of pregnancy, you can detect an embryo. But at 10 to 12 weeks of pregnancy, you can detect a fetal heartbeat with the help of a Doppler ultrasound. At 18 to 20 weeks of pregnancy, then you can notice fetal movements. And transvaginal ultrasound findings are 1 week earlier than transabdominal. So in transvaginal, gestational sac can be seen after 5 weeks of menstruation. Yolk sac can be seen after 6 weeks after menstruation. You can appreciate a fetal pole at 7 weeks after menstruation, and you can identify or detect fetal heartbeat at an early stage of 8 weeks after menstruation. Okay, it can be 10 to 12 weeks when it comes to what we call the transabdominal, but transvaginal ultrasound, Doppler ultrasound can detect fetal heartbeat so early, 8 weeks after last menstruation. And these values, they correlate with the beta HCG values as shown below. Okay, so this is just a correlation. So this will conclude our discussion on the diagnosis of pregnancy. So let's discuss the differential diagnosis of abdominal pain during pregnancy. So whenever a woman with an early pregnancy, that is amenorrhea, presents with an abdominal pain and vaginal bleeding, okay, these are a mandate for a proper evaluation. The main goal is you have to diagnose this grave condition called ectopic pregnancy, which requires an emergency management. Okay, and for the same reason, any woman with an early pregnancy with vaginal bleeding and abdominal pain, we do serial measurements of beta HCG and the serum progesterone levels to look for the proper intrauterine live fetus, and also we do transvaginal ultrasonography for heartbeat and all. And because there are not 100% accurate results are there to confirm early fetal death or location, we have to do repeat evaluations of these beta HCG, progesterone levels, and also transvaginal ultrasonography. Now let's jump into the main part, that is the differential diagnosis for abdominal pain. So whenever a woman in the first trimester or overall a woman who is pregnant presents with an abdominal pain, these are the differential diagnosis. So the abdominal pain can be from uterine conditions like abortion or miscarriage. Infections can cause abdominal pain. Any degenerating or enlarging leiomyoma or myoma of the uterus, because pregnancy supports the growth of these myomas because of the hormonal availability, and that's the reason the myomas, they become painful during pregnancy. One of the differential diagnoses for abdominal pain during pregnancy. And one more important thing is molar pregnancy and round ligament pain. So the abdominal pain derived from uterine conditions are these 5. Among these, in this video we'll be covering in detail about the types of abortions, presentation and management, and also the management aspects of hydatidiform mole, or what we call as molar pregnancy, which includes both incomplete and complete mole. Apart from the uterine conditions, even the adnexa, that means the fallopian tubes, which if there is a pregnancy in the fallopian tube, it's ectopic pregnancy. There are other sites for ectopic pregnancy, but we refer only to what we call the fallopian tube here, because ovarian ectopic pregnancies are present, abdominal, uterine scar ectopic pregnancies. But we limit ourselves to ovarian ectopic pregnancy in the next slides. And yes, the adnexal diseases such as ruptured or torsion of the ovary or hemorrhagic ovarian masses, they all cause abdominal pain. And one more thing is salpingitis. The infection of that fallopian tube can also present with abdominal pain, and tubo-ovarian abscesses. So these are the 4 entities which cause abdominal pain due to adnexal diseases. Next, yes, pain can also be due to other conditions which are non-gynecological, and evaluation depends upon the quadrant of the abdomen in which the pain is present. Okay, so we divide the abdominal pain in the quadrant basis, right? So based on the which quadrant the pain is present, the differential diagnosis is different. So the same applies to even pregnant women and also non-pregnant women. But here I am only mentioning some of the commonly seen causes like appendicitis in the right iliac fossa, cystitis here, renal stones in the lumbar region, gastroenteritis in the periumbilical region. So these are some of the differential diagnosis. Among these, what are the 3 important things which need to be discussed are abortion, ectopic pregnancy, and molar pregnancy. These 3 are associated with vaginal bleeding. So when I say amenorrhea plus vaginal bleeding plus abdominal pain, so for this triad, the differential diagnosis, main first 3 differential diagnoses are abortion, ectopic pregnancy, and also the molar pregnancy. So let's look into these things then. So when you say abortions, how will you identify abortion? So in the clinical history, okay, in the history, what are the points are the findings which favor the diagnosis of abortions? So abortion is favored by, miscarriage is favored by dilated cervix, profuse vaginal bleeding, history of, if there is any history of expulsion of products of conception, and collapse of the patient. So these favor miscarriage. What are the factors or findings which favor the diagnosis of ectopic pregnancy when there is a triad of amenorrhea, abdominal pain, and vaginal bleeding? They are normal sized uterus, non-profuse bleeding, adnexal tenderness, tachycardia, and also hypotension. So these cardiovascular instability is more common seen when there is rupture of ectopic pregnancy. What are the findings which favor diagnosis of molar pregnancy? That is, yes, there will be bleeding which is associated with serosanguinous discharge in between, and also there is passage of bits of tissue which contains vesicles, that is grape like vesicles are passed per vaginum in case of molar pregnancy, and molar pregnancy is associated with high levels of HCG. So this excess HCG causes excess vomiting. So these are the three important things. One of the differential diagnoses which needs to be considered whenever there is amenorrhea, abdominal pain and vaginal bleeding, these are high risk which requires management, observation and all. A low risk which is a natural occurrence, I can't call it as a low risk, but a natural occurrence is implantation bleeding. You should differentiate an implantation bleeding from all this. So what are the findings which favor implantation bleeding? It only occurs at the time of fertilization. It's a kind of functional menstrual disturbance, and in these cases the pregnancy test most of the times is because it is in the early phase, the pregnancy test is negative. So along with these three, there are other causes which causes first trimester bleeding. So these may not be associated with abdominal pain. So our discussion started with DD of abdominal pain. Later on, we added abdominal pain in case of pregnancy. That means amenorrhea is a common entity here. So later on what we did, later on we have added the first trimester bleeding to it. Okay, so we have discussed the differential diagnosis of the trio or the triad. Now we are only looking at the causes of first trimester bleeding, just bleeding, which are unrelated to the pregnancy. For example, cervicovaginitis, which is present even before the pregnancy, might lead to first trimester bleeding. Any vascular erosion, a presence of cervical polyps, uterine fibroids, ruptured varicose veins, any malignancy, cervical malignancy, trauma, or if the patient has a history of drug intake like anticoagulants, anti-epileptics, okay, they might cause first trimester bleeding. And if the patient has any inherited coagulopathies, they're prone for bleeding. So these are all the conditions which cause first trimester bleeding, and these are unrelated to the pregnancy. So now after the differential diagnosis, we are looking at how will you manage this case. For example, if you see a first trimester bleeding, that means first trimester means 0 to 12 weeks is first trimester. So in between 0 to 12 weeks, if a pregnant woman presents with bleeding, we do physical examination. First and foremost thing, if you're writing an answer for this question, please make sure that you check for the hemodynamic instability, because if the cardiovascular stability is not there, the first thing in the management is you have to first resuscitate the patient, and most of the times the cardiovascular instability due to first trimester bleeding is because of the ruptured ectopic pregnancy. I'm not saying that it is 100%, but the most common condition is this ruptured ectopic pregnancy, and this ruptured ectopic pregnancy requires a surgical management. So that is the first line. If there is no hemodynamic instability, then we have to check whether the product of conception are visible on the examination. For example, there are two conditions in which you see products of conception coming out. The grape-like vesicles are passed in case of hydatidiform mole or molar pregnancy, and also in incomplete abortion you will slowly see passage of the products of the conception, and most of the times it is incomplete abortion which passes product of conception. So we have to treat it accordingly. The incomplete abortion, we have to complete the abortion process here. And the non-obstetric causes like cervicovaginitis, any infection, any malignancy, they're managed accordingly. But if the patient is stable, there is no product of conception, or there is no other causes of bleeding identified. The next thing is, see, in the differential diagnosis, what we have, one thing is hydatidiform mole or molar pregnancy. Let me brief it again. Other is ectopic pregnancy. If it is unruptured ectopic pregnancy, we have to evaluate further. If it is ruptured, there is a hemodynamic instability, so based on that you can surgically manage it. And similarly, we have abortions. If it is an incomplete abortion, you can identify it with the products of conception. But if it is a missed abortion, okay, or a threatened abortion, you have to further evaluate it. So for all these three conditions, the next thing what we do is we do a TVS, transvaginal ultrasonography, and also we measure beta HCG levels. And let me quickly remind you, what is that ultrasonographic finding seen in case of hydatidiform mole? Hydatidiform mole displays snowstorm appearance, very important. So ultrasonogram gives a snowstorm appearance. Similarly, hydatidiform mole, as I told you, the presentation is with excess vomiting because of high levels of beta HCG. So the beta HCG levels are high in this case of hydatidiform mole. So let me brief you along this flow chart. So what you're doing now, you are performing a transvaginal ultrasonography and you're doing a beta HCG level estimation. For example, in TBS, you have identified sac. Instead of presenting in the uterine fundus, it is now in the fallopian tube. So now you are diagnosing ectopic pregnancy. And if there is an ectopic pregnancy, we manage it accordingly. The management part in the next slide I'll tell you. If there is a viable intrauterine pregnancy, but still there is a bleeding, that means you are suspecting a threatened abortion. See whether the baby is growing, see whether the serial levels of beta HCG and serum progesterone levels are growing properly. See whether the heartbeat is present because it's a threatened abortion. And if the bleeding continues, you can do a medical abortion in these cases if the fetus is non-viable. If the intrauterine pregnancy, if the fetus is non-viable, yes, you have to manage it like a missed abortion. If the intrauterine pregnancy, you don't know certain, like you're uncertain about the viability, then you have to repeat it. You have to, as said, you have to do serial beta HCG level estimations and also serum progesterone level estimations. And yes, there is no intrauterine or ectopic pregnancy. Okay, that means sometimes it's a completed abortion. If you don't know anything, you have to put it like pregnancy of unknown location and manage it accordingly. So this is briefly the management protocol which is used for first trimester bleeding, and our prime focus is always on looking at the abortion, whether it's an incomplete, threatened, missed or a complete abortion. Our focus is always on whether it's a viable or a non-viable pregnancy. Our focus is always on whether it's an intrauterine or an ectopic pregnancy in these cases. So I just discussed a simple and an easy way to understand the management protocol of first trimester bleeding, and this is from the reference is from the Williams Obstetrics. So why I'm highlighting here, the point is there is an entity called discriminatory zone. So what is this discriminatory zone? As you can see here, let me just take you through this flow chart. So there is an amenorrhea, positive UPT, abdominal pain and vaginal bleeding. So you are clinically evaluating the patient. First thing is hemodynamically unstable, the same thing what we discussed. If the hemodynamical stable, you are doing TVS, and intrauterine pregnancy, you're managing it properly. Abnormal also, you're managing it accordingly. If the TVS is non-diagnostic, TVS if showing ectopic pregnancy, you're manage it accordingly. But if the TVS is non-diagnostic, the first step is doing TVS, and TVS is not telling you, it's giving no information to you, then you do serum beta HCG. So when you do serum beta HCG, imagine that there is a case with the triad of symptoms, and now you have TVS non-diagnostic, and now you're looking at a serum beta HCG report. What is the first thing you need to check? You have to look at the discriminatory zone. So a number of investigators, they have described discriminatory beta HCG levels. Okay, so above these levels, failure to visualize an intrauterine pregnancy indicates that the pregnancy either is not alive or is ectopic. So that level is more than or equal to 1500 milli international units per ml. So this value is the discriminatory value. If the serum beta HCG values are more than 1500 mlu per ml, then you have to do a dilatation and curettage, because this is pointing towards the molar pregnancy. And in that case, if the chorionic villi are present, it's a molar pregnancy. If not, you have to treat it like an ectopic pregnancy. If it is not in the discriminatory zone, you have to re-estimate serum beta HCG values after 48 hours. And if they are rising, if it is exceeding the discriminatory zone, then again you have to do a TVS to identify the pregnancy. If it is non-diagnostic, you have to do a dilatation curettage and look for the chorionic villi. The same protocol applies. But if abnormal rise is there or fall is there, you can directly go back to this. So this is the importance of discriminatory zone. So when you are evaluating a patient, what are the tasks? First, clinical examination, okay, followed by TVS, followed by beta HCG. These are the three things we do in evaluating these patients. So now let's go briefly into what is ectopic pregnancy, what is molar pregnancy, how you manage it, what is abortions and not. So we're beginning with the ectopic. So when do you suspect an ectopic pregnancy? Okay, there is a pregnant woman. What are the risk factors that you have to assess? One thing is presence of congenital anomalies of fallopian tubes, any prior tubal surgery, any prior pelvic inflammatory disease, history of usage of intrauterine contraceptive devices, and history of use of progestogen contraceptives, and if it is because of assisted reproductive technologies in case of infertility, and also any previous tubal pregnancies. So these are the risk factors associated with ectopic pregnancy. What are the treatment options available for ectopic pregnancy? So the options for ectopic tubal pregnancy are both medical and also surgical. So when I say medical, we have either a single dose or a multi-dose methotrexate therapy. So the most important keyword that should come into your mind when I say ectopic pregnancy management is methotrexate. Methotrexate is given either in a single dose format or a multi-dose format. So what are the surgical treatment options available? So we are not doing open surgeries. Now we are following laparoscopic salpingostomy approach. So medical or surgical, what to choose? So this is an interesting matter. See, there is a patient with ectopic pregnancy. So women who are treated with medical treatment or methotrexate, they have a better physical functioning, okay, immediately following the therapy. But psychological functioning, there is not much differences. And also ectopic resolution success rates were not significantly different between those managed surgically and those treated with methotrexate. So these statements are taken from the latest Williams obstetrics. So what I am trying to convey here is, it's better to manage medically, because medical versus surgical, the treatment outcomes are similar. And also when you do it on a medical management protocol, immediately they have a better physical functioning, because surgery will always have a post-surgery morbidity, right? And also from various studies have concluded that women who are hemodynamically stable and women in whom there is a small tubal diameter, no fetal cardiac activity, serum beta HCG concentrations are less than 5000. So these people, they have similar outcomes either with medical or surgical management. So despite lower success rates with medical therapy, for women with larger tubal size, higher beta HCG and fetal cardiac activity, if the woman is motivated enough, you can still try medical management. So all the statements which I have just mentioned you are always pointing towards better to manage medically, though the risk is high when there is a fetal cardiac activity, beta HCG levels are very high, tubal size is very big. So even in these cases also, if woman is motivated enough, better to give medical management. So now after understanding these points, so what are the treatment options? Is there any role of expectant management in ectopic pregnancy? For example, don't give any surgical management, don't give any medical management, just wait. Can it be done? What is the indication for expectant management in ectopic pregnancy? Whenever you see a very early tubal pregnancy with either a stable level of beta HCG or decreasing or falling level of beta HCG. So what is the indication for expectant management in ectopic pregnancy? One is very early, second one is stable beta HCG levels, or third one is falling beta HCG levels. So the American College of Obstetricians and Gynecologists, they say 88% of ectopic pregnancies will resolve spontaneously if at the time of identifying or diagnosing it, the beta HCG levels are less than 200 milli international units per ml. So if someone asks you, can you do an expectant management in ectopic pregnancy? Yes, if initial beta HCG levels are less than 200. And with expectant management, the subsequent rates of tubal patency and also intrauterine pregnancy are almost comparable with surgery and medical management. But most of the times in modern obstetric practice, why obstetricians are not practicing it means it always has a potential risk of tubal rupture. See, if it goes off spontaneously, it's well and good. But if not, the biggest problem with an ectopic pregnancy is it might turn up into a tubal rupture. Okay, and that's the reason you have to undertake this expected management only in appropriately selected, motivated, counseled, educated women. So now we are looking at the medical treatment protocol for ectopic pregnancy. As I told you, management of ectopic pregnancy is synonymous with MTX. Please remember, methotrexate therapy. So this methotrexate is highly effective against rapidly proliferating tissues. So that's the reason it's an anti-neoplastic medication also. And what is rapidly proliferating here? It is trophoblast. So when you use methotrexate therapy, approximately 90% will resolute, okay, with its use. And the advantage here is you can easily administer it through an IM, intramuscular injection. You can give it either in single dose and multi-dose, and it is highly efficacious with 90% resolution rate. So what is a single dose and what is a multi-dose approach then? In a single dose approach, you can only give one dose. Repeat dose is not necessary. In multi-dose approach, you can give up to 4 doses. Okay, and you check for serial measurements of beta HCG, and doses are repeated up to 4. You wait till the beta HCG levels are less than 15%. And the dosage, as I told you, is 50 mg per meter square body surface area on day 1 is given. And not leucovorin injections are not required, but when you are giving it in multi doses, the problem with methotrexate is it leads to that it is a folic acid antagonist, right? So you have to give a leucovorin rescue therapy in these cases whenever you are giving methotrexate. So the multi-dose methotrexate dosage approach requires a leucovorin rescue therapy. So along with 1 mg per kg dose of methotrexate on days 1, 3, 5, 7, this should be followed by 0.1 mg per kg dosage of leucovorin on the alternate days, like for example 2nd day, 4th day, 6th day and 8th day. And we have to do a serial beta HCG level measurement on day 1 followed by 4 and 7, but here you have to do it on day 1, 3, 5 and 7. And in a single dose therapy, you might need to come up with a single dose again. What is an indication for additional dose? If the levels does not decline by 15% between day 4 to day 7. Okay, and also similarly, indication for an additional dose in case of multi-dose therapy is if serum beta HCG levels decline less than 15%, you have to give an additional dose, and you have to repeat serum BT-HCG in 48 hours and compare with previous value, and maximum 4 doses are given here. And post-therapy surveillance is not required in multi-dose therapy, but it is required weekly until serum beta HCG levels are undetectable. And what are the contraindications for methotrexate? Because you're giving a medical treatment with methotrexate. So before giving that, you have to rule out the contraindications for methotrexate therapy. So check for sensitivity to methotrexate. If there is an evidence of tubal rupture, methotrexate is avoided. If the woman is breastfeeding, methotrexate is avoided. Intrauterine pregnancy is a contraindication. Hepatic, renal or hematological dysfunction is a contraindication. Presence of peptic ulcer disease, history of active pulmonary diseases, and evidence of immunodeficiency, because immune cells are killed more fastly with methotrexate. These are all the contraindications for methotrexate therapy. So what is the outcome or your take home from this slide? Single dose therapy is simple, it's less expensive, and less intensive post therapy monitoring is required, and also it does not require leucovorin rescue. But still, it's better to prefer multi-dose therapy because it has a higher success rate in comparison to the single dose therapy. So it has 4 advantages, but it has the single most efficient advantage, that is, it has a higher success rate in comparison to the single dose therapy. So at the start of discussion of management of ectopic tubal pregnancy, we already discussed about whether to choose a medical or a surgical option in its management, right? So it's always better medical. But when we choose a surgical option, the reason for choosing a surgical option is for better success rate. This procedure, like there are 2 procedures for surgical management of ectopic tubal pregnancy. One is salpingostomy and other is salpingectomy. Salpingostomy means logic is simple. Just make a minor cut and try to remove it from this incision. Salpingectomy is just remove the segment of fallopian tube which contains the ectopic pregnancy and tie the rest part together. So this is salpingectomy. So salpingostomy is only used in cases of where you see a small unruptured ectopic pregnancy and the size is less than 2 centimeter in length, and also it is located in the distal third of the fallopian tube. Okay, in the distal third part of the fallopian tube you do a salpingostomy. But if the size is more, if it is ruptured, if it is in the proximal 2/3 of the fallopian tube, we choose salpingectomy. So what is the procedure? The procedure here in salpingostomy is, as I told you, we just make a 10 to 15 mm linear incision on the anti-mesenteric border over the pregnancy, and the products usually after making an incision they will extrude from this incision, and these can be carefully removed or flushed out using a high pressure irrigation. By doing that, the reason for using a high pressure irrigation system is it helps in thorough removal of the trophoblastic tissue, and this incision, that is 10 to 15 mm linear incision, is left unsutured so that it heals by secondary intention. So there is another method called salpingotomy. So they might ask you, what is the difference between a salpingostomy and salpingotomy? Salpingotomy is the same procedure, except that the end of the procedure, now you're closing this incision with delayed absorbable suture. Delayed absorbable suture. Next is salpingectomy, and as I told you, it is used for both ruptured and unruptured tubal pregnancies. And here in this procedure of salpingectomy, we use bipolar grasping devices. And why it is done? It is important to remove all trophoblastic tissue. And in most of the ruptured cases, better to irrigate the pelvis and abdomen, and they are suctioned so that it is free of blood and tissue debris. The advantage of salpingectomy is to minimize the rare recurrence of pregnancy in the tubal stem. Okay, we do a complete exception of the fallopian tube in some cases. Okay, so that's the reason we do the whole of the removal of the fallopian tube instead of just cutting it and suturing together. So that's the biggest part in salpingectomy. So that's it. That is all what you need to know about the ectopic pregnancy. So let us quickly move on to the management of hydatidiform mole or molar pregnancy. So you know the presentation part: first trimester bleeding, abdominal pregnancy, excess vomiting, amenorrhea, passage of grape-like vesicles through the vagina. These are all the features or findings which are more towards the molar pregnancy. And on transvaginal ultrasonogram, you will see snowstorm appearance, and beta HCG levels are high. So laboratory evaluation requires, along with all these, you also need to look at the creatine, liver function tests. You also need to look at the thyroid, basic. You also need to look at the grouping and typing. You might need a blood transfusion. Most important thing in the management of hydatidform mole is you have to do a chest X-ray, because sometimes these are malignant lesions. They might metastasize to the chest radiograph. Okay, and preoperatively we have to consider hydroscopic dilators also. Okay, because the treatment is suction and curettage. So for that reason, the cervix is mechanically dilated to allow the insertion of either 10 to 14 mm suction curette. And what is the intraoperative stuff what we do in management? So operation is molar evacuation by suction curettage. So we insert a large bore IV catheter. We give, this procedure can be done either in regional or general anesthesia. And what we do here, we give oxytocin 20 units in 100 ml RL for continuous infusion, and one or more other uterotonic agents may be added. For example, if oxytocin is not working, we give methergine or PGF2 alpha, that is carboprost or misoprostol, and we insert a Carmen cannula of size 10 to 12 here, and we also can do it under the sonographic guidance. So we do a surgical curettage by this intraoperative procedure. So after evacuation, if the woman is Rh negative, we have to give an anti-D immunoglobulin, which we call it as Rhogam, and we have to initiate an effective contraception after surgery, and look at the surgical pathology report of whatever moles you have evacuated. It can be an incomplete mole, it can be a complete mole, it can be a choriocarcinoma. So for that we have to do. And after doing, the post evacuation phase is very important in case of molar pregnancy, because we have to do a serial HCG level estimation in these cases, one within 48 hours of evacuation, and then please focus here, then weekly until the levels are detectable, and then until the levels are undetectable. For example, you have evacuated it on today, so within 48 hours you have to evaluate again. After that, like 2 days, you have to do the test. After that, you have to continue doing it weekly till the levels become undetectable. So once the levels are undetectable, then you have to do it monthly for 6 months. So this is the surveillance of beta HCG levels after the evacuation of molar pregnancy. And following the evacuation, the long-term prognosis for women with this molar pregnancy is not at all improved with a prophylactic chemotherapy. Okay, so that's the reason prophylactic chemotherapy is not advised by American College of Obstetricians and Gynecologists. So it's fine, you have evacuated a molar pregnancy and levels are falling, but what is the risk of this woman developing a trophoblastic neoplasia in the future following molar evacuation? Let's look at the risk factors for developing trophoblastic neoplasia following molar evacuation. Number 1, complete moles. Under histopathological diagnosis, if it is a complete mole, they have 15 to 20% incidence of malignant sequelae, whereas partial mole have only 1 to 5%. So the complete moles are more riskier to develop malignancy than partial moles. If the age of the woman is more, older age is an independent risk factor. At the time of evacuation, if beta HCG levels are very high, if they are more than 100,000 milli-international units, then it's a risk factor. And on examination, if the uterine size is large for gestational age, and if you see any thecal lutein cyst of more than 6 mm, and during the serial surveillance time, if the levels are not falling as per protocol, if there is a slow decline or slow fall in the levels of beta HCG, all these are risk factors for developing trophoblastic neoplasia following a molar evacuation. So let us now try to look at the different types of abortion seen in the clinical practice, that is the miscarriage, and how do you manage these cases. What is threatened abortion, incomplete, missed, or septic abortion? Threatened abortion means, yes, there is amenorrhea, abdominal pain, and vaginal bleeding, but on doing TVS, the fetus is viable and the os is closed. Os is closed. In these cases, we have to reassure, we have to give a proper bed rest, and you have to continue, repeat the ultrasound to check for the viability. And in case if you find no fetal activity during the serial follow-up, you have to manage it in the lines of missed abortion. So when I say missed abortion, what is missed abortion? Yes, in missed abortion, you will see symptoms of abortion, but they subside. There are symptoms, but usually they subside later, but nothing is passed out without any products of conception being expelled. So what do you do in this case? All missed abortions will be eventually expelled. You might find some delay in there. So delay of more than, okay, like for example, if there is no fetal activity, if there is a delay of more than 5 to 6 weeks in this case, the biggest problem with this missed abortion is if there is a delay in expulsion, it can lead to disseminated intravascular coagulation, which is a life-threatening condition. In those cases, you can plan either surgical evacuation or medical expulsion due to the risk of DIC. You have to wait, but if it is taking longer time, just do a medical or surgical abortion. So what is incomplete abortion then? Yes, the fetus has died. The products of conception are expelled, but they're only partially expelled, not completely expelled. So some products of conception, they are retained in the uterus. So the problem with this is these retained products might lead to infection of the uterus. Yes, cervical os is dilated and you can see the products of concepts in the uterine cavity. So this patient requires stabilization. Yes, because there is a suspicion of infection always, we have to give antibiotics to this patient. And what is the definitive treatment again? It is evacuation. In case if the cervix is dilated but not fully dilated, you can use mechanical dilatation, Hagar's dilators for sufficient dilatation. But if cervix is sufficiently dilated, you can either do a manual evacuation with finger when it is too early, between 12 to 14 weeks. And if not, you can do a suction evacuation. So last entity in the types of miscarriages or abortions is septic abortion. It's an infected abortion complicated by fever, endometritis and parametritis. So this patient should be managed in the line of sepsis or septic shock, blood, urine and cervical cultures to be taken so that you can give a proper and an appropriate antibiotic which is sensitive to the organism which is causing this sepsis. And for this, we give a broad spectrum ampicillin plus gentamicin, because IV broad spectrum therapy is given in these cases because most of the time septic abortion is because of polymicrobial infection. If there is a peritonitis, you have to do a laparotomy, you have to clean it, you have to flush it. Okay, irrigation of the peritoneum should be done. The mortality rate is high with septic abortion. So this is how you manage different types of abortions. So finally, let's look at the first trimester bleeding repeat questions. So list down the risk factors of ectopic pregnancy and how will you manage a 25-year-old woman with ruptured tubal pregnancy. Okay, you know how you manage. How would you manage a case of bleeding per vaginum with pain abdomen at 8 weeks of gestation? Simple. First trimester bleeding with pain abdomen, you have to draw the management protocol there. Discuss the differential diagnosis in a 28-year-old woman with 2 months amenorrhea and acute abdominal pain followed by bleeding per vaginum. How would you manage such patient? The whole stuff what we discussed. And a 25-year-old married lady presents with history of 10 weeks amenorrhea, acute lower abdominal pain and fainting, and on clinical examination she has tachycardia, hypertension, this should be hypotension I think, not hypertension, and pelvic tenderness. What is the most likely diagnosis? It might be a ruptured ectopic pregnancy. How would you investigate? You know, TVS, beta HCG level estimation. How would you manage such a patient? You have to list the both medical and surgical management aspects here. So that's it. This is all you need to know about the first trimester bleeding. So hi everyone, I'm Dr. Naveen. So this topic, anemia of pregnancy or anemia complicating pregnancy, is from obstetrics, and these are the 2 repeats, one in 2006 long back, and suddenly the question popped up in 2019. Okay,
and it has a weightage of 20 marks. Okay, so it indicates that this topic is very important, and we all know anemia, which complicates pregnancy, is like a kind of very important topic when it comes to preventive medicine and also obstetrics, because there are various nutritional programs which address this issue of anemia, because iron, folic acid and vitamin B12 are the major players in this topic. So these are the repeats. One is describe the causes of anemia in pregnancy. So when I say anemia, the first thing that comes into our mind is iron deficiency anemia, which is the most common cause. But still, apart from nutritional causes, there are other causes, okay, which can lead to anemia in pregnancy. And the next part of the question is, how would you manage a case of dimorphic anemia in pregnancy? So you need to understand what is dimorphic anemia. So we'll come to that in the next part of the discussion. And in 2019, they have subsections in the question 1, 2, 3, 4. What is physiological anemia of pregnancy? And second question is, do all pregnant women need additional iron? Explain in brief, which has given a weightage of 4 marks. And next is, what is the diagnostic test of iron deficiency anemia in pregnancy, and what is the reason why we use this diagnostic test in pregnancy? So that is what the question is. And next question is, how much total additional iron is required during pregnancy? And what is the distribution of this excess iron requirement in the mother's body? So more or less this looks like a question of physiology with a touch of pathology and medicine. Okay, so I am categorizing it in obstetrics because it is concerned with pregnancy. And let's get back to the discussion now. So before going into the details, let me tell you, these are what is your take home out of the discussion. One thing is, I'll give you all the causes of anemia during pregnancy. I'll also give you the definition of dimorphic anemia. And we'll discuss what are the hematological changes that occur during pregnancy. What happens to the blood volume? And what happens to the red cell volume, plasma volume, hemoglobin value and hematocrit value, etc. Okay, so we'll also discuss the ICMR classification of anemia. So at what cutoff of hemoglobin we call it as a mild, moderate, severe or very severe. So we define ranges with the help of ICMR classification. And what is the iron requirement? What is iron store in a non-pregnant female, in a pregnant female? What is required for fetus? What is required for placenta? What is required for the maternal hemoglobin mass expansion? And what is the iron amount which is lost through the gut, urine and skin? These numerical values are important because they are important both for PG entrance examinations, and you can clearly see in 2019 they asked a question about this, because when you correct anemia, okay, if there is an iron deficiency anemia in a pregnancy, when you are managing that patient, you need to give sufficient amount of iron to that lady. So how do you calculate that iron? I'll give you that formula, and when you calculate that, there is importance for an extra additional dose of 1000 mg. Why do you need it? So for that you have an answer in this slide. Okay, so it is important when it comes to the treatment aspect too. So the same continuation slide is what is the postmortem iron stores, and I'll also tell you why newborn infant of a severely anemic mother does not suffer from iron deficiency anemia. This looks like an interesting thing, because you could see in 2019 they asked questions more conceptually in clinics. Okay, and this can be a potential question. We'll discuss that. And what are the clinical features of anemia of pregnancy? How do you diagnose it? So we'll discuss the parameters available. What is the role of serum ferritin, and why we are worried about iron deficiency anemia, why it is very important for an obstetrician, because it has got consequences. Okay, it has got complications in the antepartum period, it has got complications in the intrapartum period, postpartum period, and it also affects the fetus. So this table gives you the possible permutations and combinations in which these complications can occur. Next, the final point of discussion of anemia in pregnancy is how do you treat this iron deficiency anemia. I'm not discussing the treatment of all the causes of anemia in pregnancy. Most of my discussion when I say anemia in pregnancy, it is synonymous with iron deficiency anemia because that is the most common cause. But I'll also give you the treatment modalities for folic acid deficiency too. I'll also tell you how to treat the vitamin B12 deficiency anemia also. So these are the things which we'll be discussing in this video. So please focus. There are many elements which needs clarity and I'll be giving that. So focus. First we'll start with what causes anemia during pregnancy. So what are the causes? And when do you say it's anemia? That is also important, right? You need to know when to call it as an anemia. Let me give you the values. So according to WHO, anemia in pregnancy is said to occur when hemoglobin level is less than 11 gram per deciliter. Okay, so when do you call anemia in pregnancy? What is the cutoff value? We look at hemoglobin value. And when hemoglobin value is less than 11 gram per deciliter, we call it as anemia in pregnancy. So this is further classified by ICMR, that is Indian Council of Medical Research. And according to them, mild anemia is between 10 to 11, moderate anemia is between 7 to 10, severe anemia is less than 7, and when we call it as very severe anemia, this is an MCQ. Very severe anemia, according to ICMR classification, is less than 4 grams per deciliter. Why I am stressing upon the classification? Because when we manage a case of anemia of pregnancy, you should know in which category the patient is falling. Based on that, the management approach differs. That's the reason. Okay. So this is what is anemia. Now, what causes this? What is the reason for fall in hemoglobin concentration in a pregnant female? One is acquired causes and other is hereditary. Let me finish off hereditary, which are comparably not much frequent. Okay, when it comes to the hereditary, they are not as frequent as acquired causes. So these are thalassemias, sickle cell hemoglobinopathies. There are some other hemoglobinopathies too, hereditary spherocytosis and hemolytic anemias, which are hereditary. So all these are the hereditary causes of anemia during pregnancy, which we will not be discussing here. When it comes to acquired causes, the most common in country like India is nutritional, and the nutritional can be because of iron deficiency or it can be because of folic acid and vitamin B12, which lead to megaloblastic anemia. Apart from these two, when you take postpartum anemia, that is anemia which is predominant in the postpartum period, might be because of the acute blood loss which occurs during pregnancy. So anemia caused by acute blood loss and anemia of chronic disease, that is anemia of inflammation, or because of malignancy. It can also lead to anemia, and acquired causes of hemolytic anemia and aplastic or hypoplastic anemia. So these are the various causes of anemia during pregnancy. So in anemia, we have another definition. What is dimorphic anemia? We all know what is microcytic and what is macrocytic. It depends upon the cell size. In megaloblastic anemia, which is also known as macrocytic anemia, the issue or problem is not with the synthesis of hemoglobin, because synthesis of hemoglobin requires iron. Iron leads to hemoglobin. If there is iron deficiency, hemoglobin comes down, and here the cells are smaller in size because they are not laden with, they are not completely full with the hemoglobin. So this is microcytic anemia. Whereas in macrocytic, macro means big, we also call it as megaloblastic anemia. Here the problem is not the synthesis of hemoglobin and iron. The basic problem is with the nucleus. Okay, nucleus synthesis and maturation are affected. That leads to bigger cells, megaloblastic or macrocytic anemia. If in a patient on peripheral blood smear, if in a patient, if you see both microcytes and also macrocytes. So hope you're getting my point. My point is, there is a patient with anemia, and upon conducting this test called peripheral blood smear, I could see both microcytes and macrocytes in the blood smear. This is dimorphic anemia, which is due to two deficiencies. One is iron deficiency, other is maybe folic acid or vitamin B12 deficiency. So now we are done with the definition part. Let us now jump into the core physiology. What happens to the hematological system, that is blood system in the body, when there is pregnancy? First thing is, pregnancy induces hypervolemia, that is, pregnancy leads to the blood volume expansion. It can result from both increase in plasma volume and also increase in erythrocyte count. So what is red cell volume or erythrocyte volume? Although there will be more plasma volume increase than the erythrocytes, okay, still you can see there is an increase in erythrocyte volume, and it averages about 450 ml. And this increase in red cell volume peaks early during the third trimester. So please look at this graph. So let me give you the x and y axis of this graph. X axis contains the week of gestation and y axis contains the percentage changes from the non-pregnant levels. So consider that the core base is non-pregnant. There is a subtle 20% difference at the time of delivery. See this, starting at 40, and the peak is starting after the second trimester. Okay, so second trimester is up to 24 weeks. So major change in the red cell volume, the volume of the red cell, is happening in the third trimester, and there will be like a 20% change in the red cell volume in comparison to the non-pregnant level. And after the delivery, by 6 weeks postpartum, the values are coming back to the normal state. Let me also give you the details of the plasma cell volume, which is given in a different color. Here in plasma cell volume, the changes are happening at 10th week, 20th week, 30 and 40. You can see, but changes in comparison to the non-pregnant female are in the range of 30%. Okay, so by 12th week, the plasma volume expands up to, let's say, 15%, but it reaches to a level of almost sometimes to 40 to 45% after 32 to 34 weeks. Okay, so these two, they contribute to the blood volume. So the blood volume is, if this is 30, if this is, let's say, 15 total, it becomes 40 to 45%. Okay, so this is blood volume. Plasma volume is in the range of 30%, red cell volume is in the range of 50%. Both together leads to pregnancy induced hypervolemia. 15 plus 30, 45%. So this is the major or core hematological change that occurs during pregnancy. What happens to hemoglobin and hematocrit in pregnancy? Their value decreases. Next thing. So these are the hematological changes which occurs during pregnancy. My next question is, why there is physiological anemia during pregnancy? So in any pregnancy, normally physiological anemia can occur. It is due to increase in plasma volume in comparison to the red cell mass. It's a kind of relative anemia, which is because of the hemodilution and then an apparent decrease in hemoglobin level too. Okay, so that is the reason, because of bigger increase in plasma volume than the red cell volume, there is a relative hemodilution. That's the reason you will get physiological anemia during pregnancy. So next question is, in our discussion is, how much total additional iron is required during pregnancy and what is its distribution in the mother's body? And next is, Do all pregnant women need additional iron? He is asking you to explain in brief. I am reading out the statements. Please focus here. The average iron stores in a non-pregnancy female. So this female is non-pregnant. Okay. And I am talking sole discussion is on iron levels. And they will be 300 mg in non-pregnant women. But the requirement in pregnancy is 1000 mg. I think this single statement answers this second question, that is, do all pregnant women need additional iron? Yes, because during the pregnancy the requirement of iron is 1000 mg. But in an average female who is non-pregnant, the stores are 300 mg, and it is our duty, the doctor's duty, to advise the doctor to take iron and increase the stores so that the female can cope up with the stress of pregnancy. So hence, iron supplementation is necessary to prevent iron deficiency anemia during pregnancy. So this is the basis for prophylactic iron supplementation during pregnancy. So most of the times the iron supplementation will be started in and around the 5th month, that is second trimester. Okay, I am only talking about prophylactic because there is always some confusion. You can give iron as a prophylaxis though the female is not anemic, because you need an excess stores of iron in the body. But if the female is already anemic, that means if the levels are at the start of pregnancy are less than 11 mg, we have a different algorithm. Then we don't go for a prophylactic iron therapy. We don't wait for second trimester to come. We'll start an immediate iron supplementation. So out of whatever 1000 mg which I just spoke, the additional iron store requirement, out of this, the 300 mg is for the sake of fetus and placenta. The major portion, that is 500 mg, is specifically dedicated to the mother. That is, it helps in maternal hemoglobin mass expansion. So, okay, it is specific to the mother. The remaining 200 mg out of our 1000 mg share, this 200 mg is loss. Okay, so there will be a constant loss of hemoglobin through iron through the gut, urine and skin. And the total iron needs so hope see these next few points are not important. Okay, just go through them, but we got our answer. How much total additional iron is required during pregnancy and how it is distributed in the mother's body, and do all pregnant women need additional iron. Next is explain why newborn infant of a severely anemic mother does not suffer from iron deficiency anemia. So why this question arises? Because as you can see, there is a requirement of increased iron stores in the mother. That's the reason they are physiologically prone to develop anemia during pregnancy. When mothers are developing, why not a newborn infant of even a severely anemic mother is not developing it? The answer is, I am giving you 3 statements which are supportive. Iron deficiency is often manifested by an appreciable drop in hemoglobin concentration. And in the 3rd trimester, additional iron is needed to augment maternal hemoglobin and for transport to the fetus. Because the amount of iron which is diverted to the fetus is similar in both normal and also in an iron deficient mother, the newborn infant of a severely anemic mother does not suffer from any iron deficiency anemia. Let's say instead of 3 required 1000 mg stores, if the mother is having 500 mg, okay, even though it's irrespective of whether the mother has 500 mg or 1000 mg, the body's physiological makeup is created in such a way that always look at the beauty of the nature. The mother will become anemic, but even at the cost of her severe anemia, the baby will always get her share in this. Okay, so that's the reason mother becomes anemic, but the fetus will never become, okay, anemic. The infant will never become anemic. Next, what are the clinical features of anemia of pregnancy? We all know most of the times anemic people are asymptomatic. I should start with this because mostly the body system can cope up. I have seen anemic mothers even at the value of 5 to 6, okay, 5 to 6 milligram percent, still they are asymptomatic. Okay, body adapts to the low levels of hemoglobin. The major signs and symptoms are if there is a strenuous work and all, it can lead to fatigue, low physical capacity. Even it also affects the mental capacity. The patient might develop headache, vertigo, leg cramps, pagophagia, cold intolerance, chylonychias, mucosal paleness, angular stomatitis. These are all the symptoms that's in, but common it is asymptomatic. But in the questions, if they want to give a clinical history, they say pregnant women in 32 weeks presented with fatigue, okay, low physical capacity, Koilonychia, spoon-shaped nails, very important characteristic of iron deficiency anemia. Okay, so these three are like a kind of, and also mucosal paleness or paler. It's a clinical sign. Very important. Paler is a clinical sign. So these support anemia during pregnancy. This pagophagia is compulsive consumption of ice cubes or ice drinks. It's not a characteristic entity, but because I got it from the standard reference, that is Williams Obstetrics, these are some of the clinical features mentioned there. I'm just touching upon it. What is pagophagia? Pagophagia is like compulsive consumption of. They have urge to consume ice cubes or ice drinks here. And these are all the clinical features of anemia. Next part is very important. How are you going to diagnose iron deficiency, anemia? And I'm being specific to iron deficiency here. So what investigations do you do? Foremost thing, we do CBP, which gives you a picture of hemoglobin and hematocrit. So they will be low here. And we also do the red cell indices, MCV, that is mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, and random distribution width of RBCs. So we'll do all these things, but most importantly, MCV will be is less than 80 femtoliters, which indicates that the patient might be having microcytic anemia, which is characteristic of iron deficiency. This in early stages of mild and moderate, you will see normocytic hypochromic most of the times, or normocytic normochromic. But in severe stages, the characteristic peripheral blood smear feature of iron deficiency anemia is microcytic hypochromic. Microcytic hypochromic anemia, which is a key word in this discussion. So that is what is mentioned here. And you also need to be very careful when you are examining a peripheral blood smear. Sickle cell anemia can also be seen in pregnant females. So we have to look for sickle cell to rule out sickle cell anemia in African origin. If the woman is from Africa, you need to always rule out the sickle cell anemia. And very importantly, the name itself says it is iron deficiency. So there will be low levels of serum iron. And next thing is serum ferritin levels. Very important investigation, gold standard investigation. It's a kind of like, if you want to choose one test to diagnose iron deficiency anemia, better to choose serum ferritin levels. See, when do you call it as anemia? The first test what we do is hemoglobin. But the next thing that can be done is either serum iron or serum ferritin. You got two options. And there was one beautiful question in 2019. What was that? Which investigation is preferred for diagnosis of iron deficiency anemia? You want to look at the deficiency of iron in the body. So for that you have to you have to measure the serum level of iron in the body. But this is not gold standard, because sometimes at the cost of iron stores in the body. For example, you have an iron store of some 20. In the serum you have 10. This 10 should be maintained. If this 10 becomes 5, 5 comes from here to make it 10 again, but this will become 15. That means if you want to diagnose this early stage anemia as iron deficiency anemia, you cannot just rely on serum iron values, because the serum iron values are maintained normal at the expense of iron stores. So if you can measure iron stores, you can detect anemia, iron deficiency anemia, even at the early stages of presentation. That's the reason the storage marker for iron in the body is serum ferritin. And if the serum ferritin levels are less than 10 to 15 milligram per liter, this will confirm the diagnosis of iron deficiency anemia. If there is iron deficiency anemia, it doesn't always means that the patient should develop iron deficiency anemia. So if there is iron deficiency in the body, it is not equal to iron deficiency anemia. It can be iron deficiency, but still it hasn't developed into a stage of anemia. When do you call it as iron deficiency anemia? Based on serum ferritin values. If they are very low, then you'll call it as iron deficiency anemia. Next is serum transferrin values will be very low, and total iron binding capacity will be raised in cases of iron deficiency anemia, because total iron binding capacity, it's a, like, let's say it's a molecule which binds to iron, and if this molecule is completely filled with iron, its binding capacity is low. Just imagine the iron sources. Let's not put it as I to confuse it as iodine. I'll write the ferrous, the exact chemical formula, to avoid confusion. If the iron value in the body is low, if there is iron deficiency anemia, the binding capacity of the molecule is high. So the total iron binding capacity will be raised. Total iron binding capacity values are inversely related to the serum ferritin values, because more is the serum ferritin value, less is the total iron binding capacity. This is an interplay. As I told you, not always iron deficiency presents with anemia. There will be low iron in the body but no anemia. So how will you differentiate these? Majorly, yes, you will see a decrease in iron values here. Okay, and the percentage transferrin saturation will be more than 16. Here it is less than 16. Based on that, you can say whether it's an iron deficiency or iron deficiency anemia. But more importantly, what test we do in general? In general, the test which is done is serum ferritin. If it is less than 30, it's iron deficiency. If it is even less than, that is in the range of 12 to 15, as I can see here, 10 to 15. So this will be iron deficiency anemia. And serum hepcidin values will be low in both these conditions. Serum hepcidin values are elevated in anemia of chronic disease. I'm not telling you why, but let me give you a simple clue that serum hepcidin values will be low in this iron deficiency and iron deficiency anemia, and they will be raised in anemia of chronic disease. So this can be a potential future question. What is it? What are the newer RBC parameters for diagnosis of iron deficiency anemia? Till now, whatever we have learned is the basic things what we do at the physician level: hemoglobin, hematocrit, red cell indices, peripheral smear, serum iron, serum ferritin, serum transferrin saturation percentage, TABC. Based on that, you will diagnose whether it is iron deficiency or iron deficiency anemia, and you will also rule out the differential diagnosis. That is, if there are sickle cells, it's sickle cell anemia. If the hepcidin values are high, it is anemia of chronic disease. Thalassemia is different. We do hemoglobin electrophoresis. In hereditary spherocytosis, it is different. There are so many things, because peripheral blood smear contains different cells in hereditary spherocytosis. These are all the factors which helps you differential diagnose it. But gold standard is serum ferritin. Serum ferritin value in more than 30 is not iron deficiency. Less than 30 to 15 is just iron deficiency. Less than 15, that is in between 10 to 15, is iron deficiency anemia. There are newer RBC parameters, as I just told you after this revision. So what was that? One is percentage hypo M, that is hypochromic microcytes. The total number of hypochromic microcytes in a slide. If they are normal ranges, you won't see more than 4%, that means in between 3 to 4% is a normal finding. You will see hypochromic microcytes in a normal peripheral blood smear. If it exceeds more than 4%, then it indicates iron deficiency anemia. Similarly, percentage of hypo R, that is hypochromic reticulocytes. This is wrong, okay? So spelling is wrong here. It is hypochromic reticulocytes. If they are normally less than 3.7%, if they are more than that, it indicates iron deficiency anemia again. What is the third newer RBC parameter for iron deficiency anemia? It is CHR, that is reticulocyte hemoglobin content. That is the amount of hemoglobin which is present in a single reticulocyte. If it is less than 25 picogram, it is normal. If it is more, then it indicates the iron deficiency anemia. So what is the importance here? This CHR, it measures functional iron available over last 3 to 4 days. It's a kind of, I can say, earliest indicator of iron deficiency anemia, and also response to therapy is, which can be a potential MCQ in the PG entrance examinations. What is that? The earliest indicator of iron deficiency anemia and the earliest indicator of response to iron therapy is CHR, that is reticulocyte hemoglobin count. The normal range of CHR is less than 25 picograms. What is this ratio then? M by H, microcytic by hypochromic RBC. So we are dividing the value, that is we are comparing the microcyte count as a ratio with hypochromic RBC. It is usually less than 3.7%. And what does it do? By doing this, do you remember this mnemonic SITA? That is sideroblastic anemia, iron deficiency anemia, thalassemia, and anemia of chronic disease. So here thalassemia should be differentiated from iron deficiency anemia, and the easiest parameter with the help of which you can diagnose iron deficiency and differentiate it from beta thalassemia trait is microcytic by hypochromic RBC ratio. These are the newer RBC parameters. Next thing is, what is the gold standard? We already discussed this, but let me elaborate because this was asked in 2019. Throughout the discussion, I was telling you that if you want to diagnose serum ferritin, if you want to diagnose iron deficiency anemia, anemia is diagnosed by hemoglobin. But if you want to make sure that this is because of iron deficiency, we usually do serum iron and serum ferritin. There is another gold standard which actually gives you, like, it's a kind of gold standard test, very important test, that is bone marrow biopsy. Okay, when you stain bone marrow specimen to look for iron stores with the special iron stains available, you can, with accuracy, with high sensitivity and specificity, you can diagnose iron deficiency anemia. But is it possible in a clinical setup? Can you perform this test in a pregnant woman? It's impractical, right? And it's invasive to do during pregnancy. So the next most sensitive and specific marker after the bone marrow test, that is first in the front line, the first rank goes to bone marrow biopsy, that is bone marrow biopsy and iron staining. Second is serum ferritin. So what is the role of serum ferritin in diagnosis of iron deficiency anemia? It is more sensitive and specific marker than serum iron levels. Okay, and there will be many others. Non-anemic iron deficiency is also known to affect the fetal-maternal outcome. Most obstetricians and hematologists recommend a cutoff of 300 microgram deciliter to diagnose and treat iron deficiency anemia in pregnancy. And currently, low serum ferritin values are regarded as the best confirmation of iron deficiency in pregnancy. So these are the values, that is less than 30 microgram is diagnostic. In the exam you have to write. And when do you say it is very severe, that is iron deficiency anemia, that is in between 10 to 15. And yes, gold standard is bone marrow, but next to it, the most sensitive and specific marker is serum ferritin. So what happens because of iron deficiency? Why we are so worried? Why we are actually learning this topic? Okay, why an obstetrician need to be concerned? Why a pregnant woman needs to be worried about her hemoglobin values? Because it has got many complications. Just reading out them. Anemic mother, there will be increased risk of preterm delivery. There is increased risk of premature rupture of membranes. There is high chances of preeclampsia. Intrauterine death chances are high. Intercurrent infection chances increase. Anemia increases the chances of infections in the body. And high risk of antepartum hemorrhages, that is placenta previa or abruptio placenta. The risk factor is anemia in pregnancy. and anemia is already a fluid overload condition. It aggravates it predisposes to the development of congestive heart failure. What are the intrapartum complications then? It can prolong the labor, it can increase the rate of operative delivery and also increases the rate of induction in labor. It causes fetal distress and also abruption at the time of intrapartum. And next is postpartum complications. So what happens? It increases the chance of postpartum hemorrhage, puerperal sepsis. It causes failure of lactation if not proper iron stores are given. It causes pulmonary thromboembolism, subinvolution of the uterus. Uterus after the delivery fails to involute. Okay, this is called subinvolution of the uterus. And anemic pregnancy, okay, anemia in pregnancy also predisposes to postpartum depression. What happens to the fetus then? The next is low birth weight, prematurity. Chances of infections are very high, but fetal anemia is not a usual possibility, but it can sometimes lead to neonatal anemia because that continues. And this is a controversial statement, but it can cause neonatal anemia, but most of the time they won't develop it because surplus iron stores go inside. And abnormal cognitive development, and this is rare, it's a research point. It is known that if mother is anemic, the child has more chances of increased risk of schizophrenia. Next part is treatment. Irrespective of anemia status, as I told you, we need prophylactic iron supplementation starting at 5th month of pregnancy most of the time. So this supplementation should be, yes, iron should be given, and also folic acid, because folic acid can prevent anemia, megaloblastic anemia, but more important role of folic acid is folic acid prevents the development of neural tube defects, and it is proven. So that's the reason prophylactic supplementation of 30 to 60 mg elemental iron, because formula is different. Okay, elemental iron. If you give like 200 mg of tablet, it might contain 60 mg elemental iron, and 400 microgram of folic acid should always be given. The anemia resolution and restitution of iron stores can be accomplished with simple iron compounds. That is what compounds we have: ferrous sulfate, ferrous fumarate, or ferrous gluconate. So they can provide up to 200 mg daily of elemental iron. And this is an interesting point. Okay, the preventive medicine point. What is the role of deworming in prevention of IDA? WHO recommends routine deworming with the help of either albendazole, which is single dose 400 mg, or mebendazole, which is single dose 500 mg in all pregnant patients after first trimester, because during first trimester the studies haven't proven, they might be teratogenic but nothing has proven, but still avoid during first trimester. But after the first trimester, the routine deworming is very important with the help of albendazole and mebendazole. In countries where baseline prevalence is more than 20%, that is hookworm infection and trichuris trichura, and also if the prevalence of anemia in pregnant women is more than 40, and therefore because India satisfies these two criteria, more than 20% of hookworm infection and more than 40% incidence of anemia in pregnant women, so this role of deworming in prevention of IDA applicable to India. Okay, so albendazole or mebendazole can be given to a pregnant female. So we are in the management or treatment part of iron deficiency anemia. And when I say anemia deficiency starts with hemoglobin less than level, the value, and you have to do a complete blood picture with all the indices, and you have to find that it is microcytic hypochromic or normocytic normochromic or normocytic, because macrocytic the management differs. If it is macrocytic, then you have to think in the lines of supplementing folic acid and vitamin B12, and there are some other causes which are hereditary and all. I'm not going into the details, but yes, if it is normocytic or microcytic, the next thing what you do is, if hemoglobin value is very severe, less than 4 gram per deciliter, or if you see an evident bleeding, or if you see a congestive heart failure, and if there is a hemodynamic compromise, okay, then you have to immediately perform blood transfusion. if I ask you a simple question about blood transfusion, what are the indications of blood transfusion in anemic patients? So in severely anemic patients, if hemoglobin is less than 4 and if you can see a significant bleeding and if there is any evidence of hemodynamic compromise, then you have to urgently transfuse the blood. If there is no emergency like this, if the values are not less than 4, then you have to look for whether the woman is in first trimester or second trimester or third trimester. So whatever I am discussing now, the management has a protocol based on the severity of anemia. If it is very severe, we are doing blood transfusion. But if it is not in that range, based on the values, as you can see, we are either giving an oral iron or an IV iron. I'll get back to that. But the management is guided by severity of anemia, first point. It is also guided by the stage of pregnancy. That is the second point. That is, in first trimester, the management is different. Second trimester, the management. And third trimester, the management is different. So, 2 points are covered. That is, the mode of repletion of iron stores in iron deficiency anemia of pregnancy is guided by severity of anemia, stage of anemia, and also kind of obstetric risk of hemorrhage, like if there is a premature labor, placenta previa, and also hemoglobinopathy. If the disease is chronic, the management differs based on these 3 factors. So in first trimester, if the value is more than 4 gram per deciliter, in first trimester, if the value is more than 4 gram per deciliter, and if there is no need for urgent transfusion, you can just start an oral iron, that is 100 to 200 mg elemental oral iron, and followed by see, prophylactic is 30 to 60 mg is enough, but here we are actually treating the patient on suspicion of iron deficiency anemia, that is, value is less. So in these cases, you have to at least give 100 to 200 mg elemental oral iron, and you have to follow up the patient. You have to check for the rise in hemoglobin, and usually with oral supplementation there will be a rise of more than 1 gram per deciliter at 2 weeks. That means if you are starting at 4th week of pregnancy, on first testing, if the value is 9 gram per deciliter, then at 6 weeks the value should be like 10 gram per deciliter. So you should at least note more than 1 gram increase in the value. If the response is positive, you have to continue the iron supplementation till 3 months postpartum. If you don't see any response, you check for, like, it can be a different, you check for compliance, whether the female is taking medications properly or not, because iron pills, they have side effect of GI upset or gastric upset. So that's the reason you have to check for the compliance, and it is always wide. There might be some concurrent vitamin B12 and folate deficiency. It is good to supplement that too. And if they are responding, just continue the treatment. Still after doing that, if there is no response, then we go to the other management. That means just don't worry. In first trimester, if the patient is not responding with whatever we have done, and also in second trimester, if the hemoglobin value is more than 7, we'll do the same thing. Okay, but if the value is between 4 to 7, we do a different stuff here. So we'll discuss about 4 to 7, because hemoglobin more than 7 is same again. That means a woman coming at 14 week of pregnancy with a hemoglobin of 9, what will you do? You are an obstetrician and a patient is sitting in front of you. Just write an elemental iron tablet and check after 2 weeks. That's it. If there is response, okay. If there is no response, even after giving B12, you come back to this category. That is, if the hemoglobin is less than 4 to 7, you just check for serum ferritin. If the ferritin value is more than 30, that means it's okay. The stores are well and good. Then check for CRP. Okay, then check for CRP. Why patient is not responding even after iron? The patient might be having something else, some other condition. So that's the reason. If ferritin is more than 100 with saturation more than 15, you have to rule out other causes. But if the values are coming in between 30 to 100, that means what we are trying to do here is, we are not doing serum ferritin test initially. We are assuming that iron deficiency is anemia in pregnancy is most of the times because of iron deficiency. But if the patient doesn't respond, or if the patient has in second trimester and third trimester, where you cannot wait, with a kind of value range of hemoglobin more than 7 in case of third trimester, hemoglobin between 4 to 7 in second trimester, that is a condition which needs a confirmation before treatment. In that, you have to go for IV iron, which is mostly done. See, you should not give IV iron without confirmation, right? So if you want to give IV iron, you have to confirm it. So IV iron, the patient might respond in this category. If in third trimester, if the value okay is less than 7 gram per deciliter, just look at the gestational age. If it is less than 36 weeks, you can still continue with IV. But if the value is less than 7 gram in third trimester and age is more than 36, you have to transfuse the blood. So what are the indications for blood transfusion? The blood transfusion as per this management protocol are more than 36 weeks with less than 7 gram, or any time with hemoglobin less than 4 gram with evidence of bleeding or evidence of hemodynamic compromise. What are the indications of IV iron then? IV iron indications are hemoglobin less than 7 but age is less than 36, hemoglobin more than 7 in third trimester, hemoglobin less than 7 in second trimester. So we don't give IV iron in first trimester. So please go through this management algorithm. This solves so many problems. And in the exam, if they ask about management of anemia during pregnancy, iron deficiency anemia, if you draw this management protocol, it gives more weightage to your answer. Okay. And this is not, again, see, whatever I have given you, it's taken from NCBI guidelines. The guidelines might change. Different obstetricians follow a different protocol. Okay. But I'm still going with the standard. If you write this, it's more than enough. So now you know the protocol. Now I am discussing how you are going to give iron supplementation. Iron, all pregnant women, if you are giving oral iron, I am talking about oral here, they are instructed to take oral iron empty stomach or 1 hour after meals, because food decreases the absorption of iron. For better absorption, we give it either on empty stomach or 1 hour after meals. If you supplement this iron tablet along with any vitamin C rich products such as orange juice or guava, vitamin C increases iron absorption through the gut. Okay, and these are the true things. And there are two kinds of salts in the clinical practice. One is ferric salt, Fe+3, and other is ferrous salt. Which one is preferable? Okay, which one is preferable? Always ferrous salts are preferable because they are better absorbed. But the problem is ferrous salts, they cause GI side effects. The major problem with iron, why do we check for compliance in a female? Because iron tablets, they cause GI upset. Okay, so these ferric salts, they have a superior GI tolerability than the ferrous salts. So if the pregnant female who is anemic is suffering with stomach upset and she is incompliant, she is non-compliant with the drug, better to change ferrous combination to ferric combination in this. Next is intramuscular way of giving this drug. In the management algorithm, what we have discussed, I have told you about iron, oral, IV, and also blood transfusion. I haven't touched upon a point, or I haven't introduced an IM route of iron administration, because it is in most of the times, like in most of the management protocols, they have removed it. IM route is not usually followed. But the Ministry of Health and Family Welfare guidelines for treatment of IDA in pregnancy, they are continue to recommend IM iron, that is low molecular weight iron dextran, because it's a cost effective treatment for moderate anemia in pregnancy. For moderate anemia, because in severe anemia we're giving IV dosages. In very severe anemia we're doing blood transfusion. But in moderate anemia, normally there is no zone of moderate anemia in my management algorithm. But if you see a moderate anemia in the range of what we call 7 to 11, if it is less than 36 weeks, you can still go for IM iron instead of IV iron, because IM iron is cost effective. But why in most of the institutes now we are avoiding the IM route? Because the IM route of iron injection is painful. Okay, and iron may extravasate into the subcutaneous tissue, causing dark discoloration of the skin. And iron IM root increases the risk of myalgias, arthritis, and it can cause hypersensitivity and lymphadenopathy. So to avoid all these side effects, we do that. But Indian government still proposes it because IV iron is costly. IV iron requires high risk of anaphylaxis will be there, hypersensitivity. So it requires monitoring. So they are still asking many of the lower centers to give, but in tertiary centers where I worked, we have never given IM injections. We only give IV dextran. Okay, IV low molecular weight iron dextran we give. So what is IV then? How to calculate the required iron dose? That is very important. And IV iron combines the advantage of complete bioavailability with few GI side effects, and it also gives a faster recovery of hemoglobin than the oral iron route. But the main problem is it might have some transient side effects like nausea, vomiting, pruritus, headache, flushing, myalgia, arthralgia, back and chest pain. Most of them they resolve within 48 hours of infusion. Next is Ganzoni's equation. The required iron dose. How much iron should be given? How much IV iron should be given? It depends upon this Ganzoni's equation, which is actually what target hemoglobin you are looking at and what is the actual hemoglobin. Deduct, you will get a value. You multiply this value with 2.4, and you also multiply this. This is multiplication. Somehow the system hasn't taken the symbol, and this is multiplied by the weight in kgs, that is pre-pregnancy weight. Don't take pregnancy weight because pregnancy weight increases. We take pre-pregnancy weight in Ganzoni's equation. For example, she was 60 kgs before pregnancy, and when you get a value, add 1000 mg for just replenishment of the stores. Okay, and keep on giving this dosage till you reach a target hemoglobin required iron dose. And once the hemoglobin is the normal range, we have to continue the dosage for at least 3 months. Okay, so that we can replace and at least 6 weeks till postpartum, so that you can replenish the lost body stores. So what we have discussed in the treatment, now you know the management algorithm, now you know the different routes of treatment. Okay, so the same thing is prolongated here, because sometimes now I can see in the question paper they won't ask a general question. They're being more specific by giving only 3 marks, 4 marks to each question. It has become a kind of MCQ kind of preparation again. Okay, so that's the reason I'm giving you the indications and contraindications of IV iron in pregnancy. If during pregnancy, if oral iron therapy is not taken properly, non-compliant, with the help of oral iron therapy, if the hemoglobin values are not increasing, if the woman is presenting very late in second or third trimester with moderate to severe iron deficiency, if there is a malabsorption, you cannot clearly give oral because bioavailability is poor. Similarly, bleeding diathesis, when hemorrhage is likely continuing, if you want to fastly replenish the stores, IV iron is the better option. And also in combination with recombinant erythropoietin patients with pregnancy and chronic disease, and also moderate to severe postpartum anemia when oral iron compliance is low. And if you are doubting that the woman may not come for follow-up, better to give IV iron and send her home. What are the contraindications? Because IV iron causes anaphylaxis. If there is lack of facilities for resuscitation, that's the reason IM iron or oral iron is preferred in lower centers. A known history of anaphylaxis, better to avoid it. Anyway, in first trimester we won't give it. And known state of iron overload, okay, that is a health condition, hemochromatosis, which may aggravate. In those conditions, IV iron is contraindicated. Let me quickly add 2 points or 2 slides on folic acid deficiency and vitamin B12 deficiency, because long back in 2006 they asked a question, how will you manage dimorphic anemia? In that question, if you just write anemia, iron deficiency, it's not sufficient. You also need to mention about folic acid deficiency and vitamin B12 deficiency. So in folic acid deficiency, folic acid is given along with iron and a nutritious diet is encouraged. So I'm just telling you how to manage this. And as little as 1 milligram of folic acid is administered orally once daily. Okay, and you can see a striking hematological response just with 1 milligram. And most of the times By 4 to 7 days of giving this tablet, you can clearly see a response. When you measure reticulocyte count, it will be increased. And even because megaloblastic anemia is not only specific to RBC, even the WBC and platelet count will also fall. You will see pancytopenia instead of only what we call anemia in these cases. So by giving folic acid, even you will see improvement in leukopenia and also thrombocytopenia. See, what is more important in folic acid deficiency is not just treating folic acid. The importance of supplementing folic acid is it prevents neural tube defects. That's the reason for preventing we advise periconceptional folic acid supplementation. Okay, so if you're female and you're planning for a pregnancy, you're planning to conceive, at the moment you're trying to conceive, you should start folic acid supplementation. So what is the dosage? If you are first time pregnant, just go with 400 microgram or more, because you can take any dose, but a minimal amount is 400 micrograms daily should be taken, and this should be continued until 12 weeks of gestation. Okay, and this helps in prevention of neural tube defects. And next thing is, in case if the woman is not first time pregnant, she already have history of neural tube defects in the previous pregnancy, then you cannot just give more than 400. She should take a prophylactic dose of 5 mg. See, 5 mg is the value given by WHO and 4 mg is the value given by Williams Obstetrics. I don't know which one to follow. I'm just putting out two factors here. You write one and tell them the recommendation, reference. This is the dosage of the drug that should be taken. The schedule is same again. Daily 5 mg. The moment you're trying to conceive until 12 weeks of gestation. Then what about vitamin B12 deficiency? So during pregnancy, it's useless. Like megaloblastic anemia is very rare, just on the basis of nutrition, right? There are some other causes, like if the woman has a history of gastrectomy, total or partial, okay, they might require additional dosage of like 1000 microgram of vitamin B12 given IM every month, okay, and those with this is for total gastrectomy. Those with partial gastrectomy, they can also survive. Usually they do not need supplementation, okay, but it is always important to maintain adequate serum vitamin B12 by giving IM injections of vitamin B12. There are some other conditions in which you will still see vitamin B12, Crohn's disease, ileal resection, bacterial overgrowth. In all these conditions, we give 1000 mg of vitamin B12 intramuscular every month. If you see a severe anemia just because of vitamin B12 deficiency, but why I am going very fast in this is, it's not usually seen. It's very rare to see megaloblastic anemia which is specifically because of vitamin B12. It is more common to see with folic acid, because in megaloblastic anemia, folic acid deficiency comes very fast than the vitamin B12 deficiency because of the stores which are available. So hope this has given you a clear picture of how to handle anemia during pregnancy and all of the factors which are related to it. Also go through the nutrition part of preventive medicine, wherein we have anemia programs for anemia, okay, iron prophylaxis programs, how much doses is given at what age and all. Just go through this.
Hello everyone, Dr. Naveen here. So in this video, I'll be discussing about a topic called antepartum hemorrhage from the syllabus obstetrics. So when I say antepartum hemorrhage, before going into the details, let me also tell you the concept of obstetric hemorrhages. So this obstetric hemorrhage is one of the important cause of morbidity and mortality in pregnant women. And from this we have antepartum causes. We do have intrapartum, or we'll most commonly call it as postpartum causes. From the postpartum part, we have already discussed the causes, differential diagnosis, and also the management of PPH, postpartum hemorrhage. Postpartum hemorrhage can be because of uterine tears, retained placenta,
uterine atony, which is the main cause, atonic PPH. So we have discussed this in detail in a separate video. But now, intrapartum, there are some causes that are not important, but our topic of interest for this video is antepartum hemorrhages. So be careful in the exam, like whether they're asking causes of obstetric hemorrhage or causes of antepartum hemorrhage, because both are different. So when they ask about obstetric hemorrhage, you have to mention n number of causes like coagulopathies, all the causes which are related to antepartum hemorrhage, like abruptio placenta, placenta previa, circumvallate placenta, presence of extraplacental polyps, carcinoma cervix can also be a cause of antepartum hemorrhage. Any trauma can lead to antepartum hemorrhage, that is injury to the cervical part. Sometimes the antepartum hemorrhage, the causes are unknown. So this is, for example, we call it as an antepartum hemorrhage after 28th week of pregnancy, but before the birth of the baby. So this definition is given after 28th week of pregnancy, before. And if I say intrapartum, there are so many causes, mainly coagulopathy, platelet disorders, okay, but mostly postpartum, as I already told you, atonic PPH, uterine rupture, okay, cervical tears, genital injuries, all these are the postpartum causes. So in the antepartum, we have forgot to mention one more cause here from the what I call fetal part, that is vasa previa, that is again from the circumvallate placenta. So we call that condition as vasa previa, which also causes antepartum hemorrhage. So what is your take home from this slide? Careful with the question. Look whether they're asking causes of antepartum hemorrhage or postpartum hemorrhage or obstetric hemorrhage as in toto. And what is definition of APH? You have to remember that it is 28th week and after. So after 28th week, we call it as antepartum hemorrhage. And this hemorrhage occurs before the birth of the baby. That means even hemorrhages which are occurring at the first and second stage of labor are also included in APH. So causes I have already told you. So whenever there is a question about antepartum hemorrhage, you also need to mention the differential diagnosis. For example, most frequently or most commonly asked question is, the question twists around whether the presentation is painless bleeding or painful bleeding, and like to whatever knowledge I have, whatever observation I did, it is most commonly they'll give you a 34-week pregnant. So based on this painless or painful bleeding from the vagina, you have to differentiate whether it is placenta previa or it is abruptio placenta. So you need to differentiate this. So whenever you are discussing the differential diagnosis of APH, you should always know how to differentiate placenta previa from abruptio placenta. When I say painless or painful vaginal bleeding, it means there is a visible bleeding presentation. So this visible bleeding presentation is actually seen in revealed variety of abruptio placenta, because there was a question in 1999. What they have asked is, how will you differentiate placenta previa from revealed abruptio placenta? Because if the bleeding is concealed, you cannot diagnose APH itself, right? So when I say placenta previa versus revealed abruptio placenta, in both the cases, the bleeding is sudden and mostly after 28 weeks. That means abruptio occurs in third trimester, but placenta previa occurs very close to the delivery time, maybe in first and second stage of labor. And they are differentiated based on pain, as I already told you. You will see painful in abruptio placenta along with the uterine tenderness, but painless bouts of bleeding from the vagina in a pregnant lady after 28 weeks is a diagnostic clue to the placenta previa. So there are other symptoms which helps you in differentiating these two conditions. Okay, so in abruptio placenta, most of the times the bleeding is dark, whereas it is profusely bright in case of the placenta previa. And as I told you,
the uterine contractions, they begin. Hypertonic contractions are seen in case of abruptio placenta associated with uterine tenderness, which might trigger a premature labor, and also fetal distress is very high with abruptio placenta. In placenta previa, you can, most of the times you can try expectant management because that's not that severe condition in comparison to the abruptio placenta. Here let me tell you one more point. When I say abruptio placenta, it is also called as accidental hemorrhage. So if in exam, if they ask about define accidental hemorrhage or explain the features of accidental hemorrhage or how do you manage a case of accidental hemorrhage, they all comes to the same term again, that is the abruptio placenta. Now we have discussed two conditions. The third one is vasa previa. What is vasa previa? In both these, abruptio placenta and placenta previa, the bleeding is coming from the mother. So mortality and morbidity is associated with mother. That means increased chances of death of mother, increased chance of complication. But in vasa previa, the bleeding is fetal. That means it is the fetal blood vessel that is leaking here. Okay, and the condition is again painless presentation, vaginal bleeding. But the biggest risk associated with vasa previa is it causes fetal demise. Mother is normal, nothing happens to the mother because of this, because the blood which is coming out is of the fetus. So this is one thing. And when it is during, for example, uterine rupture can also cause antepartum hemorrhage. For this, history is very important. Any previous history of cesarean section, that to classical cesarean section, might lead to uterine rupture in the later part of the pregnancy, most commonly at the time of the delivery, that is during labor. And here you will differentiate it by the patient will have severe abdominal pain will be there, but more importantly hemodynamic instability, because rupture occurs in the peritoneum. There will be peritoneal peritoneal soiling, okay, which might require peritoneal toilet while we are doing management and all. So you have to keep uterine rupture also in mind when you are dealing with a patient or a pregnant woman presenting with APH. So usual, you see, one of the biggest twist here is like you cannot diagnose APH just by bleeding, because bloody show, that means at the time of labor, at the time of delivery, there will be some blood which is coming out. It is because of regular uterine contractions and also the cervical changes. So this is small amount of blood, and this blood is most commonly it is tinged with mucus, okay, and it is close to the labor or early labor. So this is how you differentiate bloody show from any cause of APH, any other cause of APH. And next is any cervical trauma. So traumatic, you can see the cervical tears, okay, injury to the genitalia and all. It is also sudden, but there is a history of sexual intercourse or history of rape, okay, alleged rape will be there. And in this case, the distinguishing feature is you will notice history of pelvic pain, okay, and also on examination you will see a bruising or tenderness of the cervix, okay, and you might not feel an active bleeding as in case of placenta previa and abruptio placenta. So this is how we do. So what is your take home from this slide? It is very important to consider all these differential diagnoses when you are managing a case of antepartum hemorrhage, and you should be careful to differentiate an abruptio placenta from placenta previa, because they'll give you a clinical history, and based on that you need to diagnose it and manage it, because management of placenta previa is different from the management of abruptio placenta, which we'll be discussing in the upcoming slides. And we will also discuss in detail about the vasa previa part, because uterine rupture is already discussed in PPH. So why there is an APH? So there are many risk factors. So what I did is I have segregated the risk factors which are associated with placental abruption and also the placenta previa. For example, imagine there is a primea gravida. Okay, she is a primea and she is 28-year-old. For example, she is at like kind of 27 weeks of pregnancy. Okay, what are her chances of having placenta previa and what are her chances of having placental abruption based on the risk factors? For example, if there is any history of cesarean delivery. So what is placenta previa? In both the things, see what happens in the uterus, the attachment of the placenta occurs at the fundal part. Okay, from here you'll get an umbilical cord and there will be fetus like this. So here this
attachment, okay, the placenta is normal, but attachment is abnormal. So abnormal attachment of the normal placenta is placenta previa. That means instead of attaching at the fundus, it is lying close to the cervical canal. So because of that, at the time of delivery, there might be some chances of APH in these cases depending upon the severity of the placenta previa. Now, what is placental abruption? It is attached at the normal site only, but due to some reasons there will be some hemorrhage occurring because of the dislodgement of this placenta from its attachment. So this dislodgement can be mild, moderate or severe. Based on that, you will see the symptoms, and also based on the blood leakage. The blood might be concealed there, or it might come out, and we diagnose it as revealed placental obstruction. So now you know what is placental abruption and what is placenta previa. Based on this, I can tell you, like, if there is any history of prior abruption, there are high chances of recurrence. Similarly, any increase in age and also parity, and more importantly, use of cocaine abuse leads to placental abruption. This is very important. And any folic acid deficiency, sudden uterine decompressions, and hypertension during pregnancy, that is preeclampsia, is a risk factor for development of placental abruption. If the same question come in a different way, like when you're reading preeclampsia, what are the complications of preeclampsia? Very important complication is abruptio placenta. So you will be worried in a preeclamptic patient that there are high chances of placental abruption in that pregnant woman. Similarly, chances of infection are high, and chances of PROM, that is premature rupture of the membranes, and risk factor is again multifetal gestation, and low birth weight can also lead to placental abruption, hydromnios, and cigarette smoking. So what are the risk factors? Prior abruption, increased age and parity, use of cocaine, folic acid deficiency, sudden uterine decompression, pregnancy-induced hypertension, chorioamnitis, preterm ruptured membranes, multifetal gestation, low birth weight, hydromnios, and cigarette smoking are the risk factors for placental abruption. Hydromnios here is polyhydromnios, not oligo. Okay, so what are the risk factors placenta previa? That means instead of normal attachment of the placenta, it is attaching somewhere here. So why it is attaching at the abnormal places? Maybe because of any cesarean section previously, maybe any scar. So that means scar in the uterus, prior cesarean delivery, previous history of placenta previa, and also multifetal gestation, because multifetal gestation, bigger placenta attaching somewhere else, and placental anomalies, increased maternal age, multiparity, cigarette smoking. Cigarette smoking can also cause both the things, placental abruption and placenta previa, and elevated prenatal screening, alpha fetoprotein. You don't know what is the reason. Like AFP is commonly elevated in neural tube defects, but there is no neural tube defect, but there is during prenatal screening there is an unexplained abnormally elevated levels of AFP. So there are also increased risk of placenta previa. That's it. These are more than enough. Now we are coming back to the placenta previa. Now from here on, I will be discussing the placenta previa, its type and management, followed by the complications associated with the placenta previa. Then we'll discuss the abruptio placenta, its types, its presentation, and its complications, along with a new term called recurrent abruption, and also how you were going to manage abruptio placenta. And finally, we'll discuss what is vasa previa and how it is managed. So let's come back to the placenta previa. So there are four, placenta is located over or very near the internal os. There are 4 degrees. Stage 1 is low lying. So it is there in the, this is upper uterine segment and this is lower uterine segment, and it is close to the lower uterine segment. But when you look at the edge of the placenta, it is never reaching the internal os here, but it is in close proximity. So we call it as a first degree or first stage or low lying placenta. Similarly, second is marginal. It is almost at the margin of the internal os. Third degree or third stage is, we call it as a partial placenta previa, because in this case, internal os is partially covered by the placenta. And fourth degree is kind of total placenta previa, because in this internal os is completely covered by the placenta. So these are the different types of placenta previa. Now there is a case of placenta previa. You know how a patient presents with placenta previa. So most of the times it is close to the term gestation. Okay, term is more than 37 weeks, but mostly they present around 34 to 37 weeks. And when you want to manage these cases, So the presentation is simple. Mostly they'll give 34-week primary presented with painless profuse vaginal bleeding. So this is the complaint. So in the exam, if they ask a question about this, don't straight away jump to the management part. Try to mention differential diagnosis. So give provisional diagnosis first. So this is how you write. I'm giving you a clue. Provisional diagnosis. So you will start with, if there is a clinical presentation, you will start with a provisional diagnosis. So based on 34-week painless profuse vaginal bleeding, what provisional diagnosis I'll give? Because it is antepartum hemorrhage, might be due to placenta previa. So this is my provisional diagnosis. So whenever you make a provisional diagnosis, you also need to consider the differential diagnosis in this case. So when I write a differential diagnosis in these cases, what are all the things I should mention? It is not abruptio placenta because here it is painless, but abruptio is painful. Similarly, it is not vasa previa because it is the fetal part, not maternal part. Here mother is getting affected, but there is a possibility again. Similarly, it's not uterine rupture because in uterine rupture you will see painful everything and all. So whatever differential diagnosis I have given you, you have mentioned, you need to mention one point which is contradicting that diagnosis. But very importantly, after differential diagnosis, don't come to a final diagnosis immediately. I recommend you to write down the investigations that should be done to rule out this case. Okay, investigations that should be done to rule out this. And after ruling out with the help of the investigations, then your final diagnosis should be placenta previa. So what investigations are usually done in these cases? So the regular investigations which are done in a pregnant female, that is CBP, is usually done. Okay, we'll do CBP, we'll look at the hemoglobin to check for the mother's health and also the hematocrit part. We'll also do mostly the surgical profile because she might require what we call surgery later. So just write down the surgical profile and what are the components which are included in surgical profile. We'll do clotting time, we'll do bleeding time. Okay, we'll do LFT to check for the liver coagulation factors. We'll do RFT in these cases, okay, etc. So CBP, surgical profile, is usually done in these cases, but most specific investigations. So we write it as general investigations and special. So special investigations are more important here. We'll check for the ultrasound immediately to look at the fetal well-being. You might do Doppler ultrasound, okay. So ultrasound will, and we'll also check for the tests which are done for antepartum fetal surveillance. Okay, antepartum fetal surveillance, we'll do AFI test or modified biophysical profile because you need to look at the condition of the baby here. So these are the special tests which are usually done. Along with that, now comes the management part. So when you look at a case of placenta previa, so there is a case of placenta previa, your eyes should look at the following factors. First and foremost important thing is gestational age. It is not only specific to placenta previa. For any case of obstetric emergency, one of the important factors that a doctor need to look at while managing a pregnant woman is the gestational age. Okay, so if the duration of the gestational age in a placenta previa is more than 37 weeks, nothing to be done, just the baby needs to be delivered. If by any chance the mother has crossed 37 weeks of gestation, don't think. For example, 38-week primary para presented with painless bout of bleeding and all, and there is abnormal attachment of the placenta near the cervical os, everything. If it is more than 37 weeks, don't wait, just deliver. And most common method of delivery. So because I am coming to this point, the mode of delivery I will be dealing it afterwards, but before that let me see if it is less than 37 weeks what to do. That means we call it as APH only between 28 to 37 weeks, right? If it is less than 37 weeks but more than 34 weeks, so between 34 to 37 weeks, and next is less than 34 weeks, that means 28 to 34 weeks, and less than 28 weeks. What is the problem with any case managing less than 28 weeks? Because less than 28 weeks, see, anything between 37 weeks is a preterm. So the preterm, mostly they are low birth weight babies. So the preterm babies, they have their own complications. For example, if it is less than 28 weeks, if the baby is less than 28 weeks, your management is most commonly in an ICU setup, that is NICU setup, because lung maturity does not occur. So most of the regulatory mechanisms of the body haven't developed. Okay, but between 28 to 34 weeks also, there is still some immature lungs. So we have to give corticosteroids, that is corticosteroids for fetal lung maturity, either betamethasone or dexamethasone as mentioned here. But if it is more than 34 weeks, lungs might have matured properly. But from 34 to 37 weeks, just for increasing in fetal weight, you can do an expectant management in these cases. Please don't confuse. The logic is simple. If there is a case of placenta previa less than 28 weeks, we have to admit in NICU and we have to give surfactant replacement to prevent respiratory distress syndrome. But if it is in between 28 to 34 weeks, you can still try corticosteroids, because the surfactant secretion starts around 22 to 28 weeks, and it can manage, the baby can manage after the delivery. That's the reason the period of viability in India, according to India, it's 28 weeks. So between 28 to 34, you can try for lung maturity. But after 34 weeks, don't need to give steroids. But 34 to 37, we can try expectant management. Okay. So what is the expectant management if the presentation is less than 37 weeks? So the expectant management is given by or advocated by McAfee and Johnson. So we call this regimen as McAfee and Johnson regimen for the management of placenta previa. To start this expected management, what are the prerequisites? Let me give you some scenarios. It's good the baby is less than 37 weeks, because more than 37 weeks anyway we are going to deliver, we are not waiting for any complications. So this is first prerequisite. Though the baby is less than 37 weeks, you cannot just practice this regimen. The reason is, if in that hospital setup, if blood transfusion is required, if it is not available, you cannot take a risk. So availability of blood is one of the prerequisite. Similarly, at the time of management, if you need to do a cesarean section within 24 hours, if that facility is not available, don't do expectant management. Simply send it to a tertiary center. Similarly, if the health of the mother is not good, for example, hemoglobin is less than 10, anemia itself is a complication. Upon it, if there is an hemorrhage and all, patient might go into hypovolemia or shock. So look at the general health condition of the mother. And this thing we already discussed. So there shouldn't be any active bleeding which is happening when you're doing expectant management. Expectant management is only tried when there is a mother with a history of painless bleeding, but now she is okay. And also we will be doing fetal well-being tests, and if the fetal health condition, fetal heart rate pattern is good and all, in those conditions only we do expectant management. So what are the things that we do in expectant management? Not strict bed rest, but bed rest is advised in case of placenta previa. And similarly, we will be estimating hemoglobin, and most importantly, you will be looking at urine for protein, because you have to rule out any concurrent preeclampsia, which can be a possibility here. And also we have to do a blood grouping and typing, because in case you might need a blood transfusion. These are the general stuff what we do. And keep looking for inspecting for any bleeding, because that takes out the patient from a prerequisite again. So that's a contraindication for expectant management. And we have to do a continuous fetal surveillance with ultrasound. And if the mother needs any hemoglobin supplementation or blood transfusion, hematemnics, we have to do it concurrently. And very importantly, the problem with these placenta previa or abruption placenta is there is chances of feto-maternal hemorrhage and mixing up of the fetal blood with the mother blood. Whenever this happens, for example, if the woman is Rh negative, okay, sensitization might take place. Okay, Rh negative pregnancy, and that's the reason we have to give anti-D immunoglobulin, or Rh immunoglobulin should be given to all Rh negative unsensitized women. And this part, corticosteroids are given if the baby's gestational age is less than 34 weeks, and dose is mentioned here. And uterine contractions per se are not a contraindication for expectant management, but mild uterine contractions, if they are present, we can manage them with tocolytics. So you can give magnesium sulfate, can be given. Okay, and that too if the fetus is extremely premature. When to stop this expected management? You have to while you are starting expected management, within 24 to 48 hours, you have to reassess the condition. If there is by any chance active bleeding or evidence of any fetal distress, okay, we have to immediately plan delivery irrespective of the gestational age. But if the gestational is more than 37 weeks, don't wait, immediate delivery. So whenever there is a term called delivery in case of obstetrics, you need to know which route. Okay, I cannot straight away say cesarean section is the only option, or I cannot straight away say normal delivery can only be done. There is no yes or no here. Okay, there is no white and black. There is always a gray zone of mode of delivery. In choosing mode of delivery, you have to look at the permutations. Okay, you have to look at the combination of clinical presentation. So similarly, what is the route of delivery in placenta previa? You cannot choose between cesarean section to normal delivery, because based on the condition you have to do. But most preferred method is cesarean section. Okay, so for example, the baby is in primary healthcare setup where there is no obstetrician available to do a cesarean section. So if there is no facility, don't at all try normal delivery. Just send the patient to a tertiary setup. So vaginal delivery in a case of placenta previa should never be attempted outside the operating room in any patient with placenta previa. Okay, so we have to admit the patient. Next thing is, lower segment cesarean section is almost always preferred, and it should be scheduled between 36 to 37. But if there is an early onset, we have to do it. And similarly, you can do vaginal delivery or induce a labor, okay, in the operating room. You have to take her to the operating, then you can induce, in case if the mother is hemodynamically stable and also fetal cardiac state is reassuring. And one more prerequisite is if the placenta lies more than 2 centimeters away from the internal os based on the ultrasonographic finding. So this is where you can just try for vaginal delivery in case of placenta previa. So hope we are done with detailed types management part. Let's look at the complications. So these days they are asking what are the maternal complications and what are the fetal complications associated with placenta previa. So what is maternal complications? It can be APH, antepartum hemorrhage, malpresentations, premature labor, prolapse of the cord, intrapartum hemorrhages, early rupture of the membranes, very importantly postpartum hemorrhage. APH can cause PPH, retained placenta, and puerperal sepsis are the maternal complications associated with placenta previa. Similarly, fetal complications are very important. It can be low birth weight, it can be birth asphyxia, it can be IUD, birth injuries can occur, and there are high chances of congenital malformations, almost 3x high chances of congenital malformations in patient with placenta previa. So in a fetus born to a placenta previa mother. So these are the complications which are seen with placenta previa. Let's now quickly jump into the next part, that is accidental hemorrhage or abruptio placenta or premature separation of placenta. Let me tell you the exact term to describe this. Premature separation of normally implanted placenta is abruptio placenta. Premature separation of abnormally implanted placenta is placenta previa. As I already told you, there is a revealed variety which we usually discuss. There is a concealed variety, but most of the times it is not completely concealed. It is a mixed variety because there will be some bleeding which is coming out. That's the reason I am putting only 2 columns of differentiation here. One is revealed, other is mixed, in which the concealed features will predominate. Now let's try to differentiate these two. Among these two, revealed is the most common type, and patient presents with abdominal pain with bleeding, and this bleeding is the shock in these patients is proportionate to the amount of blood which is seen. But in these cases, yes, you will see abdominal pain but slight or little bleeding, and these patients have shock which is pronounced out of proportion to the visible bleeding. And when you look at the pallor, also similar, it is related to visible blood loss, but severe pallor with mild blood loss is a characteristic feature of concealed or a mixed variety. And when you look at the height of the uterus, it is proportionate to the period of gestation, but it is disproportionate because in concealed variety what happens, there will be blood which is concealed in the uterus which might give you an abnormal fundal height. That is, fundal height larger than the gestational age can be seen in case of mixed varieties. And fetal heart sounds,
Revealed variety is not that much dangerous, usually present, but mixed or concealed variety is dangerous because you are not coming to the clinical assessment at the earliest because of the concealed nature of the presentation. And when you look at the features of preeclampsia is risk factor for this APH, and this association with preeclampsia is commonly seen with mixed variety or concealed variety, which is a frequent association. But even in revealed cases also it might be present. So this is how you differentiate two types of or three types of accidental hemorrhage or abruptio placenta. Now we'll come back to the complications later. First, let's discuss the management part. Then I'll tell you what is recurrent abruption and what are the complications associated with abruptio placenta. So how are you going to manage a patient with abruptio placenta? There is a table, but I'll give you a simple small flowchart for this. So when there is a case of abruptio placenta, that means painful bleeding with uterine tenderness positive, abruptio placenta. The problem with abruptio placenta is chances of high maternal mortality. Okay, so you need to manage it properly. There are two approaches for it. One is general approach, wherein usual stuff for any obstetric emergency. You have to monitor the vitals, look at the hemodynamic control, maintain proper airway. If there is hypovolemia, volume resuscitation is important. Make sure that you have a blood grouping and typing. And very importantly, if you notice any coagulopathy by doing tests and all, you have to correct the coagulopathy if necessary, and RH negative pregnancy in case we have to give RH prophylaxis to avoid sensitization by the RH negative mother. These are general approach. I'm not going in details of it, but what is more important for us is specific approach. Okay, so in this specific approach, as I told you, gestational age is always important, but here symptoms play a vital role. For example, there are three possibilities. Possibility number one, fetus is normal. So fetal assurance, fetus is normal and mother is also normal. In both these conditions, if fetus and mother normal, there is abruptio placenta. So we have to observe, avoid proper bed rest, okay, and also regular care. I won't call it as a control, we'll give a regular care in these patients. And we'll continue this observation bed rest up to 34th week. Okay, so up to 34th week we'll continue this, but as I told you, if the age is less than 34, we have to look for the fetal lung maturity, and if there is any contractions, we have to try tocolysis similar to the placenta previa management. And you always need to aim for a normal delivery in these patients. So it's the same. Fetal assurance is there, mother is normal, from the baby has crossed 34 weeks, now she is in the range of 34 to 37 weeks. Okay, in the range of 34 37 weeks, if it is going fine, it's well and good. But if there is any chance of active uterine contractions, then you have to do normal vaginal delivery. Okay, and if there is no active contraction, no signs of fetal distress, there is no bleeding, you can continue it till the completion of 36. That is, up to 37 weeks you can continue the expected management. So after 37 weeks you can happily deliver the mother. So this is how you manage a normal thing. But in case if there is an acute symptoms, acute bleeding, increase in uterine tenderness, active bleeding, in all these cases, but still the fetus is live fetus, but mother is having symptoms, don't look at the fetal age, just do an emergency cesarean section. Don't even try for normal delivery. Do an emergency cesarean section because mother is having active symptoms. But if the fetus is dead and mother is having active symptoms, okay, what you need to do? No need of putting further morbidity on the mother by doing cesarean section. If the fetus is dead, you can try. You can induce a vaginal delivery. You can give pharmacologic uterine contraction inducers like oxytocin, okay, and you can do a manual opening of the amniotic sac and try for the normal vaginal delivery. But if there is any deterioration of the mother condition, don't do a normal delivery. Even in the case of dead fetus also, you have to do an emergency cesarean section. Logic is simple here.
Nothing to worry. You'll do general approach. But problem with abruptio is expected management is also tried, but we are not giving the name as McAfee regimen and all. But what is more important is again more than 37 weeks, just deliver, don't wait. But less than 34 weeks, look for the fetal lung maturity and all. But between 34 to 36, by any chance, if there is an active contraction, try vaginal delivery. But no contraction, okay? But no active contractions, but no signs. The active contractions, if there is any sign, then it comes to the live fetus part where we'll do emergency section only. If there is any mother symptom, do emergency section. So this is how you manage abruptio placenta. Now, what are the complications which are associated with abruptio placenta? So one of the important complication which can be a future question is covular uterus. So it is also called as uteroplacental apoplexy. So where do you see in this? It is seen in severe type of concealed. So the bleeding is concealed inside the uterus. So that is, there is massive intravasation of blood into uterine muscle. So blood entering into the uterine muscle is covular uterus. And when do you usually see this covular uterus? When you do a laparotomy for cesarean section, at that time you might observe this covular uterus. And per se, covular uterus, how it is managed, you can ignore it. You say there is no need to do hysterectomy in these cases. When you look at this image, you will be tempted to do a hysterectomy and remove the uterus. No, the hematoma will come off. This is not an indication to do hysterectomy. Covular uterus is not an indication to remove uterus. This is one of the complications. There are other complications associated with abruptio placenta. It can lead to intrauterine fetal death. It can lead to, very importantly, when I say maternal DAC or when I say amniotic fluid embolism, please remember, if there is any clinical presentation similar to disseminated intravascular coagulation or amniotic fluid embolism, it is a dictum that most of the maternal DIC and amniotic fluid embolism are because of the abruptio placenta. Okay, very important. And hypovolemic shock will be there because of the hemorrhage. Hypovolemic shock, if not treated at correct time, the brunt of attack falls on the kidneys, leading to acute kidney injury. Sheehan syndrome or pituitary apoplexy is a common entity with PPH, but very rarely it can also be seen with abruptio placenta. Please don't get confused. Sheehan syndrome is a common complication with PPH, but it can also be seen with abruptio placenta. So these are 5 complications, and we have discussed the covular uterus in detail here. Now let's quickly jump into another entity called recurrent abruption. For example, let us assume there is a woman with a history of abruptio placenta. When you're counseling this woman on follow-up sessions and all, she will ask you, what are my chances of developing abruptio placenta in the next pregnancy? Okay. See, problem with abruptio placenta is whatever risk factors we have discussed, for example, cocaine abuse, multi-fetal gestation, okay, multi-parity, everything, these predisposing factors are chronic, they are repetitive. So it would be reasonable to conclude that the placental abruption have a high recurrence rate. Okay. And if there is a case of history of abruptio placenta plus fetal death, the chances almost doubles. Okay, extraordinarily high risk of recurrence in these cases. And also, if there is history of 2 abruptios, the risk for the third pregnancy increases up to 50-fold. So that's the reason any management of pregnancy which is subsequent to an abruption is difficult, because, for example, abruption in the previous pregnancy has occurred at 34 weeks. There are high chances that it can occur early in the coming pregnancy. So there is no proper study done on this. I can't give you a recurrence rate, but when I say recurrent abruption, there are high chances of recurrence. For example, there is a history of recurrent abruption after third delivery or after second delivery. If the baby is fine, don't encourage subsequent pregnancy. Advise them for family health planning, because the chances are high in the next pregnancy. So these are the few things you need to understand. So now we are done with the management of abruptio placenta and the complications and the types, the presentation and all. So with this, we have finished placenta previa and abruptio placenta, which are very important. You also need to put some focus on this vasa previa. So what is this vasa previa?
there is a special entity called velamentous insertion of the umbilical cord into the placenta. We call this condition as velamentous placenta. So what is happening here? Usually the umbilical cord should go inside and divide. Here, before entry into the placenta itself, the umbilical cord branches are dividing, and these tiny minor branches are liable for damage at the time of delivery. They might rupture, and the problem is here the bleeding is not from the mother, it is from the fetus. So the unsupported umbilical blood vessels in the velamentous insertion of the placenta, they are close to the presenting part. They run across the cervical os, and at the time of delivery these vessels are torn either spontaneously or at the time of rupture of the membranes, leading to APH. And this bleeding is fetal in origin, it is not maternal. This point I am stressing because it is the fetal which is under increased risk of mortality and morbidity, not mother. And how will you diagnose this case? We have to do a color Doppler to look for an antenatal diagnosis, and this goes into the special investigation part. So when there is a case of vasa previa, how do you manage? There is a case of vasa previa with the help of color Doppler, but there is no bleeding. You have to admit the patient in between 28 to 32 weeks, and please plan an elective cesarean section to avoid fetal based on the fetal lung maturity. And if there is a bleeding, you have to do an immediate emergency cesarean section, and the fetus or the baby or the neonate might require blood transfusion in this case. So this will conclude our discussion on antepartum hemorrhage. So these are the previous year repeats. Let me quickly go through them. A primi gravida complains of vaginal bleeding. So antepartum hemorrhage. What are the causes? How will you differentiate placenta previa from the revealed variety? You cannot differentiate it from concealed part and all. So revealed variety of abruptia, we have discussed this. So discuss placenta previa in detail. Please do write types, symptoms, differential diagnosis, presentation and management. And define accidental hemorrhage. What is accidental hemorrhage? As I told you, accidental hemorrhage is abruptia placenta. How would you manage a woman at 34 weeks of pregnancy who comes to casualty with history of painful? That means you have to write the management of abruptia placenta at 34 weeks. So you can try for expectant management from 34 to 37. But after 37 you have to deliver. Everything I have just discussed. And they're asking to mention you the fetal and maternal complications associated with accidental hemorrhage. So the fetal we have already discussed. The mother part also we have already discussed. Next question is, define antepartum hemorrhage. How would you manage a patient at 34 weeks of pregnancy who comes to casualty with history of painless? So they're asking about placenta previa, and they're asking the management part and also the fetal and maternal complications. And next is a primi gravida at 34 weeks with history of painless. Same again. Okay, the same question got repeated in 2016. And in 2018 there is a twist here. Please don't get confused. Of late nowadays, there is this concept called vertical integration in medicine which is happening. Even if you look at the latest MCQs from NEET PG, AIMS PG, All India entrance examinations, so what is happening is, if I want to ask a question from anatomy, I am not asking directly a question from anatomy. The examiner is want to test your vertical integration. That means they want to link different subjects together. This is the classic example. Write notes on issues you would raise in counseling a woman about to be delivered at 28 weeks gestation after placental abruption. So what we usually think when you look at placental abruption, we think that it's an OBG question. But here they are asking about counseling of a woman who is a pregnant woman, counseling and all. It comes into PSM because mother care, MCH, maternal and child health care concepts. And similarly, you look at the age, it is 28 weeks. Any baby who is born less than 37 weeks is a preterm. So now we are handling a baby who is preterm baby. So it's a PEDS. So this vertically integrated questions are now a dictum in your paper 2 of the UPSC Medical Sciences 2. So when you observe it, you will see a preventive aspect. You will say an MCH, mother, and also child healthcare accept. And you cannot say whether this question is a part of PSM or an obstetrics or a pediatrics. They are linked together now. This is very important, and there are more and more questions which are coming from this. And in our UPSC grant test January session, we have almost like 70-80% of the paper 2 section B part. We tried to
frame questions in vertically integrated manner. Though you might feel tough, but this is the latest trend. Nothing new. For example, when I say counseling, it's okay. But when I say 28 weeks, management of a preterm infant is in syllabus in pediatrics. How do you feed it? How do you manage respiratory distress syndrome? How do you feed? How do you manage a low birth weight baby? And management of what I call placental abruption is there in obstetrics, which we just discussed. So we have to club them together. I'm giving you like how to write this answer. So 28 week gestation is a preterm infant. Okay. So what are the issues you want to discuss with the mother while counseling her? The major issue is the mother will ask you, like, when are you going to get discharged? So when will you discharge a sick baby? So the sick baby is always discharged when she starts breastfeeding. So when will the baby start breastfeeding? Most of the times, please remember, the suckling pattern starts probably at 34 weeks of age. Before that, she can't feed properly. So the suckling maturity comes at 34 weeks. But now babies between 28 to 31 weeks usually are managed on nasogastric tube feeding. Or if she is not taking feeds properly in the nasogastric tube, we have to give IV fluids. Okay. And if she is feeding well, so if she crossed 31 weeks, then you can try feeding with pal dye. Okay. And after 34 weeks, you can start exclusive breastfeeding. So development of the fetal feeding habits are important in deciding when to discharge. Okay. So that is one thing the mother is concerned about. So you need to write about diet or feeding guidelines here. Similarly, at the time of counseling, the mother might also need to know the chances of recurrence. You have to tell her that too. Don't worry about respiratory distress syndrome, but still you need to tell her the baby might require corticosteroid injections. Prophylactic are given before the delivery. So after the delivery, after 28 weeks, less chances of RDS, but still there are chances. So respiratory support might be required in the baby. So this is one more thing what we do. And we also tell her danger signs at the time of discharge in any preterm infant. So in any preterm, you have to give her danger signs. For example, if there is any difficulty in feeding, if there is any lack of movement, temperatures, that is management of hypothermia, we have to suggest kangaroo mother care. If the respiratory rate is very high, if there is severe chest indrawing, if there is history of convulsions. So what I am trying to convey here comes the role of IMNCI guidelines, which is in syllabus again. You have to know the danger signs in this baby so that the mother can come back. So always arrange for a follow-up after the discharge within 3 to 7 days in any case of preterm infant. Normally, we advise a follow-up after 6 weeks. But because it's a preterm infant, we have to advise a follow-up within 3 to 7 days. So this is also very important. Along with this, you have to give a normal essential care, that is practice hypothermia, prevention of hypothermia, how it is done, what are the nutrients to be given, what are the supplements to be given, okay, what is the extra care that should be given, for example kangaroo mother care and all this needs to be advised in this mother. So look at the recurrence chance, advise about counsel her about chance of recurrence, counsel her about feeding, give her danger signs, tell her when to come back and all these are a part of which should be raised. And this is an interesting question again. So this will conclude our discussion in detail on the antepartum hemorrhage, its causes, presentation, complications, management. So welcome everyone, Dr. Naveen here. So this video I'll be discussing about the hypertensive disorders in pregnancy. So I can also call them as pregnancy induced hypertension, or gestational hypertension is also another term. So there is minor variations in this. I'll be discussing the definition part in detail to avoid confusion, because in the exams they're asking once about the management of eclampsia, once about the management of preeclampsia, and in the very recent exam that's specifically asking about antihypertensive therapy, because treatment of this hypertension in pregnancy includes treating hypertension and also neuroprophylaxis, that is prevention of seizures by the magnesium sulfate, what we call Pritchard's regimen. So we will be discussing that part also in this, and parallelly along with the definitions, see, let me finish off this. We can also write it as preeclampsia. Preeclampsia can also be a superimposed preeclampsia, which is again a recent question in 2019. I'll be discussing that. And we also have eclampsia. And other thing is chronic hypertension. That means a pregnant woman, she's hypertensive even before the onset of pregnancy, and this hypertension is continuing during her pregnancy. So these are the various terms which we'll be discussing in the later part of the video. So here, when I say hypertensive disorders in pregnancy, the parent term is hypertension, right? So with regards to hypertension, see, this topic itself, hypertension, is very important for your exam. And in the hypertension, you take physiology. So in the physiology, we have covered factors affecting cardiac output and factors which are regulating the BP. So regulation of BP is an important topic which we already covered. And next is you take pharmacology. In pharmacology, I did give you the details of antihypertensive medication in the cardiovascular system. So antihypertensive medications, their side effects, their mechanism of action is also important. And very importantly, in the medicine, we did discuss about the causes, mainly pertaining to the secondary hypertension, and also the guidelines in detail. So to end this spectrum of hypertension, which is high yield topic for your exam, even in the what we say interview part also, like hypertension, diabetes, the chronic diseases which are bothering the country are usually frequently asked. So in this spectrum, so now we are ending this by discussing the pregnancy induced hypertension in detail. Okay, so before starting this topic, I'll give you two things. First thing, what are all the things that I'm going to cover? Second thing, I'll also list out the various questions which are asked previously. So let's see the things which I'm going to cover, like an introduction. So I'll tell you why hypertension is a part of deadly triangle, a brief discussion about the epidemiology of hypertension in pregnancy. We'll also discuss the classification part in detail with definitions. And when I say hypertension in pregnancy, the bothersome is always preeclampsia. Per se, hypertension, that is BP more than 140/90, is not scary, but if it is associated with proteinuria or some of the danger signs, then we call it as a preeclampsia syndrome, and this preeclampsia syndrome is even more dangerous. So I'll give you the detailed diagnostic criteria for preeclampsia syndrome. And very important thing when it comes to the management of PIH, if you are an obstetrician, if you're practicing obstetrics, and if you see a pregnant woman with hypertension, you should always be looking at the gestational age of the baby, because if it is preterm, the management is different. If it is if the baby is viable, okay, post 34 weeks, the management is different. And also based on the severity, if it is mild, you can manage it conservatively. If it is very severe, then the only treatment available is delivery. So if you understand the differentiation between a severe and a non-severe preeclampsia, your decision about managing the patient depends upon this classification. So though this table looks like cluttery, this part is very important, because you should be able to differentiate severe from non-severe hypertension in pregnancy. Yes, the definition part will continue, and I'll also add a few points about this interesting concept called delta hypertension. Why this is important? Because of late, when you observe the trend of the examination, they're not asking you lengthy questions. Suddenly, out of the most frequently or most commonly asked topic, yeah, they're picking up a rare thing. Okay, they're giving 2 to 3 marks, they're allotting it, but they're asking it. So with this hypertensive disorders, I think delta hypertension is a potential future question. So I'll give you the concept about delta hypertension in pregnancy. So I'll also teach you the risk factors, and very importantly, the etiopathogenesis, the mechanisms which are behind the development of hypertension. Why in pregnancy this hypertensive disorder is seen in first place. You should understand that, because if you know that, then the management part becomes easy for you. And yes, we'll also discuss the role of prostaglandins in it. And next thing is very important thing. This can be again a 2-mark question. What is HELLP syndrome? So we'll discuss in detail about the HELLP syndrome. And their off late management always includes investigations and also the treatment part. If you directly jump to the treatment part when you're writing an answer, if you miss investigations, you won't get the full marks for that question. I think knowing this latest trend, that is the predictive test for the development of preeclampsia. For example, you take a woman is supposed to develop hypertension during her pregnancy. If you can identify this early in the pregnancy, you can take proper precautions. So I'll also tell you the predictive test and also what are the preventive options available. If available, are they properly evaluated with the help of randomized trials? So we'll be looking into that in this. And lastly, yes, the most important part which is frequently asked is how do you manage a case of preeclampsia and what are the delivery options available, like whether it is a conservative or true, like is it a conservative or a radical approach, that is delivery irrespective of the gestational age, or like what is the management protocol? Because in the exam, if you write down the protocol, management protocol, that will fetch you more marks than writing theory in paragraphs. Okay, so whenever they ask about management, make sure that you write a management algorithm, and I think that is what we are doing for all the whatever we have discussed so far. I'm giving you the management algorithm for most commonly asked diseases. And yes, management includes antihypertensive therapy, which is recently asked in the exam. And also when I say anti-epileptic therapy, epilepsy in pregnancy is not always preeclampsia. It's very important when you write an answer, please mention differential diagnosis part. Okay, so I'll be covering that. And this concept is very important. We not only give magnesium sulfate to a woman with preeclampsia, that is seizures, we also give it as a prophylaxis. This is a new concept. So this magnesium sulfate neuroprophylaxis is given two parts. One is continuous IV infusion, other is intermittent intramuscular injections, that is Pritchard's regimen. Most of you are aware of Pritchard's regimen, but there is a change in the latest trend. Now we are only giving intravenous continuous infusion. But the problem with continuous IV infusion is you need to be sure about measuring the serum magnesium levels to avoid toxicity of magnesium. That is, hypermagnesemia can lead to respiratory depression and it's a life-threatening condition again. So that's the reason in peripheral tertiary hospitals in developing country like India, we still use Pritchard's regimen. So I'll differentiate continuous IV infusion from intermittent intramuscular injections, and we'll also discuss the benefits and risks in this video. And finally, we have started with management of preeclampsia. Let's also discuss the management of eclampsia. So yes, this video is a lengthy video. We are covering so many aspects of PIH, but I personally feel you should know it because this is very high yield topic. As you can see, discuss the management of premigravida, 36 weeks with a BP and 1+ albuminuria. See, they're not straight away asking you management of preeclampsia or eclampsia. Rather, so they're giving you this gestational age and criteria for severity. So that's the reason I'm spending more time in discussing the criteria of severity and also the management algorithms. So this question dates back to 1994, but off late you can see diagnosis, management of PAH at 38 weeks of gestation. Again, gestational is there given, and discuss the management of eclampsia at 37 weeks of gestation, and how will you manage a case of severe preeclampsia at 34 weeks of gestation, and describe the management of pregnancy induced severe hypertension. So it's a kind of what we call a global kind of question. So then you have to decide whether it is less than 34 weeks of gestation or it is more than 34 weeks of gestation, because the algorithm differs. In general, management is more than 34, but in less than 34 we follow a conservative approach. So we'll be describing or discussing that. And finally, in 2019, very recent question, what is gestational hypertension, what is superimposed preeclampsia, and what is the role of antihypertensives in preeclampsia? So we'll be discussing all these things in detail in this video. When it comes to the complications which usually occur during pregnancy, that is complications of pregnancy, there is a deadly triangle. That is, there are 3 diseases which are actually the cause of most of the maternal mortality. And out of them, very important one is hypertension. When I say hypertension, it's a global term.
Okay, they complicate almost 5 to 10% of all pregnancies. But in this, the more grave one was the development of preeclampsia. That is not mere elevation of the BP will cause the death of the mother or increases the morbidity or mortality. It is actually the preeclampsia condition, which is a part of deadly triangle. And the other part, other two aspects of the deadly triangle are, one is hemorrhage and also the infections, or we also call it as sepsis. So why I'm telling you this? Because you need to understand the grave concern of hypertension in pregnancy and its importance. Okay, as an obstetrician, you should handle it carefully with the available knowledge of all the latest updates. And next is the classification part. When I say hypertensive disorders in pregnancy, first thing is gestational hypertension. So gestational hypertension is not preeclampsia. Gestational hypertension is a simple term wherein there is an evidence of there is no evidence of preeclampsia. That is, if the BP of a pregnant woman who is normotensive, before the pregnancy she is normotensive, but during her pregnancy her BP is more than 140/90, but she does not have any preeclampsia. It's a normal hypertension. So we call it as gestational hypertension. And this hypertension which is developing during pregnancy, it will resolve automatically after delivery by 12 weeks postpartum. So after 12 weeks of postpartum, most of the times she won't be having any high levels of BP. So this is a simple terminology, or how do you define gestational hypertension. Next is preeclampsia. So in preeclampsia we have a diagnostic criteria. That means in preeclampsia is also a new onset of hypertension in a normotensive woman during her pregnancy. The same BP cutoff, but now she'll have a diagnostic criteria. So in preeclampsia what we have is a proteinuria. Okay, so previously, like 5-6 years back, the proteinuria was like the most important diagnostic criteria. But now the latest guidelines say, yes, the presence of proteinuria is a criteria for preeclampsia. Even if proteinuria is not present, even if there are other symptoms which are present in absence of proteinuria, you should classify a gestational hypertension as preeclampsia. So proteinuria is, yes, a criteria, but it's not a definitive criteria to diagnose preeclampsia. This is the latest thing. So yes, proteinuria is present, preeclampsia. If proteinuria is not present, it is still preeclampsia if there are few parameters which are satisfying in the criteria. So I'll be discussing that in the next part of the slide. And when I say eclampsia, eclampsia is preeclampsia plus simple seizures. Development of the seizures is eclampsia. And the main goal of management is prevention of development of seizures, because this eclampsia can lead to so many complications during the delivery. Okay, so high complication rate is associated with development of eclampsia, high mortality rate. So that's the reason we prevent seizures. That's the reason we give neuroprophylaxis when you diagnose preeclampsia. And next is chronic hypertension. So in this chronic hypertension is simple. The woman is already a hypertensive. She now entering into the pregnancy, and this chronic hypertension can later on become preeclampsia. Just focus here. This term is important because in 2019 they asked this question. Define superimposed preeclampsia. Normal preeclampsia is different. Superimposed preeclampsia is the woman is already hypertensive during her non-pregnancy state. Now, upon that, yes, her BP levels are high. Now she has preeclampsia upon it. So this is preeclampsia superimposed on chronic hypertension, or we call it as a superimposed preeclampsia. So this is how you classify hypertensive disorders in pregnancy. And among them, what is most dangerous? Yes, definitely preeclampsia syndrome, either alone or associated with superimposed on chronic hypertension, is the most dangerous entity, which leads to high mortality and morbidity in pregnancy. Now the same thing is mentioned here. I'll just quickly go fast. Gestational hypertension, yes, BP more than 140/90 after 20 weeks. in a previously normotensive woman. So this 20-week criteria is very important because at this point of 20 weeks, the pathophysiological changes happen in the placenta, in the spiral arterioles of placenta. Therein, there will be an increased resistance to the flow of blood, in turn leading to hypertension development. So it's related to this age of 20 weeks. So before 20 weeks, for example, there is a woman of 16-week pregnancy has a BP of more than 140/90. Okay, at that point of time, you won't call it as a gestational hypertension. You diagnose gestational hypertension after 20 weeks. So she will be like a chronic hypertensive. Okay, if you are diagnosing at 16 weeks, you might not have checked her BP previously before pregnancy, so you can't call it as a normotensive. So there will be a tracking, regular measurement of BP during the antenatal visits, just to make sure that this happen. And this 20-week cutoff criteria is very important here. So next is pre-eclampsia syndrome. So pre-eclampsia, what is the definition? Because they ask it, define pre-eclampsia. Pre-eclampsia is best described as a pregnancy specific syndrome. It's a syndrome that can affect virtually every organ system. Every organ system. See, when I say thrombocytopenia, blood platelets are affected. When I say renal insufficiency, kidney is affected. When I say liver involvement, liver is affected with elevated serum transaminase levels. Okay, and also cerebral symptoms, even brain is getting affected with headache, visual disturbances and convulsions, and even lung is getting affected, that is pulmonary edema. So this preeclampsia syndrome, why it is a part of dangerous triad? Because it can affect virtually every organ system of pregnancy. So it's a pregnancy specific syndrome. It's seen in only pregnancy. You cannot call preeclampsia in a normal woman. It is related to pregnancy and it can virtually affect every organ system. So that itself will conclude our diagnostic criteria. As I already told you, hypertension plus proteinuria. What is the criteria for proteinuria? That means if you are collecting a 24-hour urine sample, it is very important to collect 24-hour urine sample. And in this urine sample, on quantification of the protein, if the protein levels are more than 300 milligram in a 24-hour urine sample, then it is proteinuria. Or if you're not calculating it for 24 hours, rather you're doing a protein by creatine ratio. Sometimes creatine is elevated. So in those cases, the patient might be having a chronic kidney disease or proteinuric conditions before. So already a patient with serum creatine elevation, you cannot take this criteria of 300 mg. He might be having 300 mg passage of proteinuria before the pregnancy. So to rule out that, the more specific indicator is you have to take a protein by creatine ratio which is more than or equal to 0.3. So these two, what we call more definitive criteria of 24-hour urine sample. But sometimes it's not always possible to collect a 24-hour urine sample. Okay, when if these two tests of 24-hour urine sample, that is the proteinuria and also protein creatine ratio, if these two tests are not available at that point of time, you can just take help of the dipsticks which we have in the casualty, okay, or office setup. So take the dipstick and look for 1+ proteinuria. 3+ is nephrotic range, right? So here it is 1+. That means 1+ indicates 30 mg per deciliter of protein. If dipstick 1+, 30 mg per deciliter is, this value is persisting after repeated usage, then it can also be taken as a diagnostic criteria for the gestation preeclampsia. So as I told you, the latest guideline says proteinuria is not the sole criteria. Even if proteinuria is not present, in hypertension plus evidence of multi-organ involvement, thrombocytopenia, platelet count less than 1 lakh, renal insufficiency, creatine elevated, liver involvement, AST, ALT elevation, cerebral symptoms like headache, visual disturbance, convulsions, and also pulmonary edema. This Task Force 2013 guidelines are very important for diagnosis of preeclampsia. If someone asks you what is preeclampsia, I think you have a clear idea. If there is a pregnant woman after 20 weeks of gestation with a BP more than 140/90, with either proteinuria or evidence of multi-organ involvement like thrombocytopenia, renal, LFT, cerebral symptoms, pulmonary edema, then you will diagnose. So if I ask you how will you investigate this case, it's very simple for you to write, right? So in the investigations part in the answer, you can surely mention CUE, that's complete urine examination, which also includes
the dipstick test, protein creatine ratio. Okay, and also you have to do CBP to look for platelet count. You also need to do renal function test to look for elevated creatine, because renal insufficiency can be a possibility. And you can also write LFT, liver function test, to look for serum transaminaseless elevation. And you also need to what we call eye examination to look for any visual disturbances, and also chest x-ray and auscultation to look for the pulmonary edema. These are the basic investigations you can write in your answer. And yes, as I told you, just mere diagnosis of preeclampsia is not gonna help you in properly managing these cases. What is the reason? Because when you look into the questions, they clearly say either they give you a less than 34-week gestation, or they give you more than 34-week gestation. So based on that, they also give you a value of BP and also the presence of proteinuria. Or now they can even give you the presence of thrombocytopenia, liver and kidney involvement. So in that scenario, you need to know if it is a preeclampsia. You need to know whether it's a non-severe one or a severe one. See, logic is simple. When I say non-severe, this includes both mild and moderate. I went into so much of literature to prepare this content, and see, mostly we follow Williams obstetrics because of the recent past. When you observe questions, they are direct paragraphs from Williams obstetrics, right? Latest edition. So in that, they have clearly given one thing. Okay, non-severe category includes mild and moderate hypertension, but there is no specific definition when to call mild, when to call moderate. Just it's up to the obstetrician, what you call a subjective variation. See, one thing looks mild for me, for another obstetrician it might look a moderate thing and all. So to avoid confusion, because there is no specifically defined criteria to differentiate mild from moderate hypertension, they are just calling it as non-severe hypertension. So please don't confuse. First thing is, there is a pregnant woman. It's a mandatory because it's a pregnant specific symptom. Next thing what you do in diagnosis is you check for BP value. If it is more than 140/90, your second step is done. Third thing, you will see for proteinuria and also other symptoms by doing investigations to classify it as a preeclampsia or just normal gestational hypertension. If it is preeclampsia, based on these criteria, you can differentiate it as a non-severe or a severe preeclampsia. These are the few steps which you follow as a practitioner. Now, if it is a non-severe, that is mild to moderate, based on the gestational age, if the gestational age is less than 34 weeks, the pregnant woman hasn't attained viability age. That means it is between 23 to approximately 34 weeks. If it is in between that, you can try an expectant management or a conservative management. You can wait, you can admit the patient, you can constantly regularly check whether the patient is developing a severity. But if it is very severe, there is no role, what we call it as in severe cases, the only treatment, the only curative approach for preeclampsia is delivery. Okay, and what choose, is it a normal delivery, is it a cesarean delivery, how to do it, what other treatment should be given to control hypertension, everything in a management protocol we'll be discussing that. But for you, for a basic knowledge, check for pregnancy, check for BP, check for diagnostic criteria, classify it as non-severe or severe. If it is non-severe, look for gestational age. If it is less than 34 weeks, you can try expectant management. See here, I told you 23. If it is less than 23, no use. You have to terminate the pregnancy, not delivery. It is called termination of pregnancy, MTP. Okay, if it is less than 23 weeks as per Williams. So here, this is a general overview of the protocol. We'll discuss in detail, but for you to have a knowledge, I have just covered it here. So now we are at what step? We are at classifying it as non-severe or severe. So that's the importance of this slide. Let's look at the parameters. 160 by 110. See, the diagnostic criteria is 140/90. But if it is less than 160/110, it's non-severe. But if it is more than or equal to 160/110, then it's a severe thing. Okay, so in the exam, if they give the BP is 160/110, don't confuse. It is more than or equal to. So that means they are discussing about the management of severe preeclampsia. And now
Proteinuria, yes, none to positive, because presence of proteinuria will not differentiate a severe from non-severe hypertension. These are the other parameters which help you in judging severity. That is headache, visual disturbances, upper abdominal pain which indicates involvement of the liver, oliguria which indicates involvement of the kidney, convulsions, eclampsia which indicates involvement of what we call CNS, serum creatinine, yes, kidney, thrombocytopenia, the vascular system is getting affected, which might lead to a profuse bleeding and death of the patient, and elevation of the serum transaminase, which is marked elevation, not minimal, and fetal growth restriction if it is obviously seen, and if there is a pulmonary edema. All these, if any one of this is positive, then it is a severe along with the high hypertension. Okay, now you have a clarity about differentiating non-severe from severe. Let's look at here. A caveat is that differentiation between non-severe and severe gestational hypertension or preeclampsia can be misleading because let's say the patient has come at 38 weeks. Now she is non-severe. I'll tell you, within 1 hour she can become severe, because the time range is very short. Patients from mild disease, they can progress very rapidly to the severe disease. So you cannot always rely on this criteria. So that's the reason continuous monitoring after admission of these patients is very important. So we'll also see when to admit these patients, when to stop expectant management and do the delivery. But for you, this slide will give you information about differentiating non-severe from severe hypertension. So let me quickly give you a recap of what we have discussed so far. I gave you the definitions part. So I did tell you about gestational hypertension and preeclampsia. Now we'll see eclampsia. Eclampsia is simple. In a woman with preeclampsia, a convulsion that cannot be attributed to any other cause. I told you at the introduction part that when there is a convulsion, it is not always because of preeclampsia or eclampsia. You have to rule out the differential diagnosis. After that, in a woman with preeclampsia, if there is a convulsion, then it is eclampsia after ruling out the differential diagnosis. And what kind of seizures you will see? You will see generalized tonic-clonic seizures, and they can appear either before the delivery or during the delivery or after the labor. And next thing is chronic underlying hypertension. If the BP is more than 140/90 before pregnancy or before 20 weeks of gestation or both. So this 20-week cutoff is very important when you take history and also when you look at the questions in the exam. And I already discussed about preeclampsia, which is superimposed on chronic hypertension. So this is superimposed preeclampsia, and this is very recently asked. What is superimposed preeclampsia? If a new onset or a worsening hypertension is accompanied by new onset proteinuria or other findings in a case of chronic hypertension, then it is a superimposed preeclampsia. Let me give you just a small example. A 32-year-old primigravida who is a known hypertensive now presented with, for example, she has a baseline BP of 146/92, which classifies her as a gestational chronic hypertensive. Now upon it, now the BP has become 160 by, let's call 100, 158/100, and also it is now associated with new onset proteinuria. Then now we'll call her as superimposed preeclampsia. Why not pure preeclampsia? Pure preeclampsia condition is this: 28-year, previously 120/80, but now she has more than 140/90 plus proteinuria. Why I am going into minute details of this discussion? Because it is very important for you to differentiate these two. It is very important for you when there is a patient, is it a superimposed preeclampsia with a previous history of hypertension or a new onset hypertension with pure preeclampsia? Because pure preeclampsia, it develops very late in pregnancy. She might not require regular checkups. But if it is superimposed preeclampsia, because it develops very early in pregnancy, so the complications are coming very early. So you should be cautious in this regard. You should be more careful when it is superimposed preeclampsia. So the same thing, pure preeclampsia is a bit less severe, but superimposed preeclampsia is more severe. And one more basic problem with superimposed preeclampsia is it is accompanied by fetal growth restriction. It not only causes complications in the mother, it also affects the growth of the baby. So that's the reason for a doctor, it is always important to differentiate a superimposed preeclampsia from pure preeclampsia. Okay, see, let me tell you one thing. This discussion also tells you about a bit of change in the trend of the examination, because they're going more specific. They're asking from the same topic. They're not going off the syllabus, but they're making sure that you're covering this minute black holes or emptiness in the concepts. Okay, so this is superimposed preeclampsia. Next is delta hypertension. This concept is also very important. So let me just recap what we're doing. So we have started with the classification. I'm giving you the definitions. You know the definition of gestational hypertension. You know the diagnostic criteria for preeclampsia syndrome. You know the indicators of severity. You also know the definitions of eclampsia and chronic underlying. They might come up with what is delta hypertension then. Okay, that is also a possibility. Now we'll see into what is delta hypertension. See, in PSM, there is a phenomenon called tracking phenomenon. That means you track BP of some particular age groups from birth to a particular criteria. The same tracking is done if it is done in pregnancy females. That is, you are taking BP on y-axis and week of gestation in pregnancy on x-axis. And we have taken percentiles for reference in the black. That is 5th percentile, 50th percentile and 95th. That means within these two standard deviations, it is normal. Now you see, these are the normal BP ranges. You have a patient A, you have a patient B. We are tracking their BPs by regular antenatal visits. We are measuring their BP and we are marking it in this graph. Please careful. This is patient A and this is patient B in red. Patient A, look at the BP. The values are not mentioned, but let's assume that it is 110. Okay, 110 by 80 kind of stuff. 110 by 80, 110 by 80, 105 by 79. It's in the range of 110, 110, 110. It is now just 118 by 88 kind of stuff. So this, as you can see, from the patient A tracing is different from this patient B tracing. So this 95th percentile is 140 by 90 because we are taking it as a reference range to diagnose it as hypertension. Now in this patient, just focus, though the patient here is not satisfying a diagnostic criteria of hypertension, the BP is not 140 by 90, it is 130 by 89 only. But the main problem in this patient is there is a sudden rise in mean arterial pressure. So this BP is MAP, mean arterial pressure. The normal value is 105. So if there is a sudden rise in mean arterial pressure in the later part of pregnancy, and this is not more than 140 by 90, it is less than 140 by 90. Okay, so this is called as delta hypertension. It's not preeclampsia, it is not gestational hypertension, it is not chronic hypertension, it's nothing, it's just delta hypertension. Why it is important to know this concept? Let me tell you one thing. Though they don't have hypertension, this will give you or tell you that it is very important to continuously track the blood pressure of a pregnant woman, because though she is not coming into the criteria of 140/90, but still she can develop eclamptic seizures or HELP syndrome even though she is normotensive because she has delta hypertension. So look at the importance. There is a female, 32-year-old, normotensive, but she hasn't been to much of the antenatal visits. There is no tracking of the BP. And let's say on 38th week, just before the delivery, her BP was 135 by 85, but still this value is below the preeclampsia. You're happy as an obstetrician, but suddenly she develops eclamptic seizures or suddenly life-threatening HELP syndrome. HELP syndrome is hemolysis, elevated liver enzymes and low platelet count. This is a typical example of a delta hypertension. So delta hypertension concept tells you that though the BP value is low, be careful. Tracking of the BP is very important in females. It also indicates the importance of regular antenatal visits in the first trimester, second trimester, third trimester, and noting down the BP regularly will give you this concept of delta hypertension. What you'll do, you'll be more careful in these people with delta hypertension. Okay. Now we have discussed the classification, epidemiology, okay, the definitions part, delta hypertension. Let me also tell you which pregnant women are prone to develop these conditions. That is
preeclampsia or eclampsia. It is actually young and nulliparous women who are prone to develop preeclampsia. In what we call gravid women, multiparous women, old women, rather than preeclampsia, they are more prone to develop chronic hypertension in the later part of their life. Okay, so chronic hypertension will be multiparous and also aged patients. Rate, ethnicity, genetic predisposition, they also play an important role. I'm not going into the details because it's not important. Even environment, season, socioeconomic status can also influence the development of hypertensive disorders in pregnancy. Obesity is a very important risk factor. Multifetal gestation, more than one fetus. Maternal age, if it is low, if it is young, more chances. Hyperhomocystinemia can also lead to hypertension. Metabolic syndrome, it contains hypertension. And also history of the same condition in the previous pregnancy will also carry a risk. So without mentioning it, if I put smoking, you will accept it, because smoking is associated with so many risks. Like, it is a part of risk factor for so many disorders in pregnancy. But surprisingly, here don't mention smoking in the preeclampsia or hypertensive disorders, because smoking is actually protective. Why? Smoking upregulates a placental adrenomedullin expression. Remember this. What is smoking doing? It is upregulating the expression of placental adrenomedullin. What does it do? It regulates volume homeostasis. Blood pressure depends upon the volume. If volume is properly regulated with the help of placental adrenomedullin, okay, the adrenal gland, the aldosterone is the one which regulates. The same thing we call it as placental adrenomedullin. Smoking increasing placental adrenomedullin, which in turn regulating the volume homeostasis, less chances of developing what we call a reduced risk of hypertension. You just call it as a reduced risk. Please don't mention it as protective, because protective means you have to suggest how to smoke, which is not right? So it's not ethical. So it reduces the risk of hypertension during pregnancy. So don't mention smoking in the risk factors. So now let us discuss about the mechanisms which lead to development of hypertension in pregnancy. So there are 4 mechanisms. Number 1 is the implantation of placenta with abnormal trophoblastic invasion of uterine vessels. Among the given 4, this is most important mechanism. We all know BP, that is blood pressure, is regulated by the resistance vessels. The resistance vessels in our body are arterioles, and arteriolar diameter will regulate the blood pressure in the body. For example, if there is a vasoconstriction here, okay, if there is an increased resistance in a vessel, this leads to increased blood pressure. Applying the same concept with regards to the hypertensive disorder in pregnancy, if you can see here in this image, this is the schematic representation of normal placental implantation, and you can see proliferation of the extravillous trophoblast. So this is extravillous trophoblast which is getting proliferated from the anchoring villus. So what you see here is anchoring villus, and what you can observe here is a proliferating extravillous trophoblast. And these trophoblasts, what they're doing, they're invading the deciduum of the uterus, and they are extending into, as you can see, extending into the walls of the spiral arterioles. So in comparison to the normal BP, as we all know, the arterioles are the resistance vessels in the body. So similarly, the spiral arterioles of the uterus are the resistance vessels. So for BP to be maintained normal, the spiral arteriole diameter should be increased. Okay, they should be made dilated for the low resistance. In the first picture here, the first part of the image, the right sided part, these trophoblastic cells which are actually invading the deciduum, okay, which are actually invading the walls, the endothelium of the spiral arterioles, this process of invasion is defective here. So that's the reason the diameter of these spiral arterioles is not increasing or dilating. The resistance is not coming down, and this high resistance leads to hypertension in pregnancy. In the second scenario on the left side, there is a proper invasion of the trophoblastic cells. There is a proper dilatation of the spiral arteriole, and you can see there is a low resistance conduit here, and this reduces the BP. And this is very important mechanism which leads to gestational hypertension. So with preeclampsia, as given in the sentence here, there is defective implantation which is characterized by incomplete invasion of the spiral arteriolar wall by these extravillous trophoblasts, and this leads to, or this results in, small caliber vessel with high resistance to the flow. So this is one of the mechanisms. So we are discussing the mechanisms which leads to hypertensive disorders in pregnancy, and we have discussed in detail the first thing. There are other mechanisms which are also important, but I am not going into the details of this. The second is immunological maladaptive tolerance between maternal, paternal, that is from placental, and also the fetal tissues. And the third mechanism is maternal maladaptation to cardiovascular or inflammatory changes of normal pregnancy. So mother is not able to adapt properly to the changes which are happening during the normal pregnancy. And the fourth mechanism, which is also important, is genetic factors of the mother which actually influence the development. Okay, so inherited predisposing genes and epigenetic influences of the mother also will lead to development of hypertension. But the most important thing is this one, placental implantation with abnormal trophoblastic invasion. So remember this, abnormal trophoblastic invasion. Next, and as I have seen some of the previous year questions, okay, therein hemophiletic theory of hematopoiesis, okay, monophyletic theory of hematopoiesis. There are some more questions where they ask theories about vitiligo formation or vitiligo development. So there is one theory which might be important for your exam, which is a two-stage disorder theory of preeclampsia, which can be a potential question in the future. What is this? Two-stage disorder theory of preeclampsia, which explains the etiopathogenesis of the preeclampsia. So there are two group of scientists, one is Ness and Roberts and other is Redman and co-workers. In different years they have proposed this theory. Okay, according to the two-stage theory of Ness and Roberts, the two-stage disorder includes both maternal, mother develops preeclampsia, and even the placental preeclampsia. According to the Redman and co-workers, there are two stages. Stage 1 is because of the faulty endovascular trophoblastic remodeling, okay, and that in the next stage leads to the clinical syndrome. Both are explaining the same mechanism, that is the placental implantation with abnormal, but they say that these occur in two stages. First, the mother changes in the maternal changes, then followed by the changes in the placenta, which leads to the clinical syndrome. So importantly, stage 2 is the one which is susceptible to modification by the pre-existing maternal conditions. For example, endothelial cell activation and inflammation. So these kind of things are actually modified by the other factors like immunological maladaptive tolerance, maternal maladaptation, genetic factors, epigenetic influences, environmental influences. So all the risk factors, they can actually show their effect in the stage 2. Okay, so the same are given here, as you can see: cardiovascular, renal disease, maternal diabetes, obesity, immunological, hereditary. All these can influence the stage 2 of the two-stage disorder theory of preeclampsia for the etiopathogenesis. And as I can tell you, so these are old theories which are obsolete. Okay, but such compartmentalization of what is happening for stage 1, stage 2 is artificial.
Okay, and it seems logical to us that preeclampsia syndrome presents clinically as a spectrum of worsening disease, starting at mild, then moderate, then severe, that is non-severe and severe preeclampsia. So these are the mechanisms. So we are discussing the etiopathogenesis, under which we discussed mechanism. The same thing is covered here with the help of a diagram. So now let me ask you one thing. What is the role of prostaglandins? Because in PG entrance examinations, I had seen few questions in this aspect. So what is this? In comparison to the normal pregnancy, this prostacyclin, that PGI2 production, is decreased in preeclampsia. So I had seen questions. Which of the prostaglandin levels are low in a pregnancy-induced hypertension or preeclampsia in comparison to the normal pregnancy? What is that? It is prostacyclin, and this is because of an action which is mediated by phospholipase A2. So at the same time, the production of another component, that is thromboxane A2, is increased in the platelets. So because of this, when you take a ratio of prostaglandin I2, that is prostacyclin, by thromboxane A2, what happens? This is coming down, this is going up. So the ratio actually decreases. So this can be a potential MCQ, but it is also important for you. What is the role of prostaglandins in the pathogenesis of preeclampsia? That is, decreased prostacyclin, increased thromboxane A2, or the ratio decreases. The ratio of prostacyclin and thromboxane A2 decreases. So because of whatever changes which are happening, okay, change 1, change 2, and change 3. You know what are the changes. So because of these changes, the net result is an increased sensitivity of the blood vessels to infused angiotensin 2. Okay, already the spiral arterioles, because of the issue, they are constricted, but because of the changes which are happening in the autocoids, that is the prostaglandins, these blood vessels are now even more sensitive to angiotensin which is released in the body. So angiotensin, angio, vessel, tensin means tension, that is constriction. Ultimately, this leads to vasoconstriction again. And these changes, they happen predominantly between the window period of 20 to 22 weeks. So that's the reason in our definition, I did tell you that if it is more than 20 weeks in pregnancy in a normotensive, if you see an elevated BP, then it is preeclampsia. Because this is because of whatever pathophysiological changes which I just explained it to you are happening during this time period. So this will conclude our discussion on the etiopathogenesis, or the mechanisms which lead to preeclampsia, and role of prostaglandins in it. Let us briefly discuss about the HELP syndrome. So whenever we discuss PIH, so it is incomplete without knowing this important syndrome. This is important in two ways. Any preeclampsia with HELP syndrome, it's a grave sign because the mortality and morbidity increases because of it. Second thing, when you're following a conservative management in a case of preeclampsia, if you're following a wait and watch approach, the development of HELP syndrome will give you an indication to terminate or deliver the baby. So what are the components of this HELP syndrome? It is hemolysis. In a patient of preeclampsia, if you see hemolysis, elevation of the liver enzymes, and the low platelet count. So it's just a component of the whole severity scale. So as you can see in the previous the section of this video, there are so many components: visual disturbances, development of the convulsions, proteinuria, low platelet count, involvement of the liver, which is indicated by elevated liver enzyme levels, aminotransferase level elevation, hemolysis. Okay, so when you see all these components, out of them only 3 have been taken which got more importance, that is hemolysis, elevated liver enzyme, and low platelet count. But let me tell you one thing. If someone asks you what is HELP syndrome, you can just say this abbreviation. There is no universally accepted strict definition for this. But the problem is there are so many complications which are associated with HELP syndrome. For example, people with HELP syndrome are more probable to develop a subcapsular liver hematoma. They're more likely to develop eclampsia,
placental abruption, acute kidney injury, aka kidney failure, pulmonary edema, stroke, coagulopathies, ARDS, acute respiratory distress syndrome, sepsis. So there are some complications associated with HELP syndrome, and you should be careful in that aspect. So this much is more than enough brief discussion about the HELP syndrome. This part is very important. If someone asks you what are the predictive tests which can tell you the development of preeclampsia syndrome, whatever the clinical manifestations, the lab diagnostic parameters which we have seen just now throughout the discussion of PIH, that is pregnancy induced hypertension, all those are parameters which are seen after the development. But is there any test which helps you in predicting the development of preeclampsia syndrome? The answer is yes. There are some markers, that is biological, biochemical and biophysical markers, a group of markers which are measured either during early pregnancy or across the pregnancy. They might give you an idea. They have been proposed to predict its development, the preeclampsia syndrome development. So what kind of markers we are looking at? One thing is, if there is any faulty placentation, can you identify it with the help of an early marker? It can be a useful thing. If there is a marker which indicates impaired placental perfusion, it can also be a marker. If there is any marker which indicates improper endothelial cell activation and dysfunction, which is one of the mechanism in development of what we call preeclampsia syndrome. And is there any parameter which helps in identifying the activation of coagulation at the earliest? So these we are looking at these aspects to identify the early markers. So with the knowledge, whatever research is done, there are some tests in these aspects. For example, placental perfusion or development of vascular resistance is indicated by either rollover test, isometric hand grip or cold pressor test, pressor response to aerobic exercise, angiotensin II infusion, mid-trimester mean arterial pressure measurement, and platelet angiotensin II binding property, renin levels, 24-hour ambulatory BP monitoring, uterine artery or fetal transcranial Doppler velocimetry. So these are some of the tests which are predictive with regards to this component, that is placental perfusion or vascular resistance. This is just memory part. You have to remember at least 3 or 4 out of it. Next is fetal placental unit endocrine dysfunction. So endocrine, so you will be looking at the hormones, okay, PAPA, inhibin A, activin A, placental protein 13, corticotropin releasing hormone, CRH, A disintegrin, ADAM12, kisspeptin. So these are all the endocrine hormones which indicates the fetal placental unit endocrine dysfunction. And if you want to look at the renal dysfunction early, these are the parameters: uric acid, microalbuminuria, and renal markers are like urine calcium or kallikrein, microtransfer in urea, N-acetyl beta glucosaminidase, cystatin C, and podocytinuria, which indicates acute kidney disease at the earliest, like the cardiac biomarkers what we have. What are those? Cardiac biomarkers are troponin I, okay, troponin T, LDH, myoglobin, CKMB, creatine. All those are markers for cardiac failure at the earliest. So similarly, we have renal cardiac markers like uric acid, microalbuminuria, all this whatever just I mentioned. If you want to find out earliest the endothelial dysfunction or oxidant stress which is put on the body, you can do platelet count and activation test, fibronectin test, endothelial adhesion molecules. So I don't want to read everything. These are all like static part. Just go through all these markers which can indicate endothelial cell dysfunction. If you want to remember 3 or 4 which you can remember. For example, VEGF is easy to remember. And also endothelin, neurokinin, just whatever you choose, just remember it. There are some other markers which are also useful in predicting the development of preeclampsia syndrome, like antithrombin 3, ANP, beta 2 microglobulin, but all these are research related. Okay, so if you can remember this first 3 or 4 parts is well and good. Okay, it's all research related stuff, but very important. Just imagine, before development of BP, high BP, before development of eclampsia, before development of HELP syndrome, before biochemical abnormality development, if you can identify these patients, you can be more careful. Like, you can do some preventive stuff to prevent it. But let me tell you, when it comes to the prevention of preeclampsia by knowing these early markers, there are some methods which can prevent preeclampsia that have been evaluated in randomized trials. Okay, that have been evaluated, but just read the last line of this slide. In general, none of this has been found to be convincingly and reproducibly effective. So my point here is, what I want to convey, what you should take home is, yes, you can know the development of preeclampsia with predictive tests, but you cannot prevent it 100% because we're still working on it. The research is going on, but there are some methods which can but not proven. For example, the first one, dietary manipulation. We all know hypertension can be prevented by low salt diet, and calcium and fish oil supplementation is very important. We usually do it in second trimester, the calcium supplementation part. Similarly, exercise. The physical activity is advised. Stretching exercises are advised, and there is a role of prophylactic, diuretic and antihypertensive drugs to prevent it, but it's not proven. Similarly, antioxidants are always useful, like C, E and D, and antithrombotic drugs are also in research, like giving low dose aspirin, aspirin dipyrimidine, aspirin plus heparin. The combinations are tried in different randomized controlled trials, but what is your take home? None of this is found to be convincingly and reproducibly effective. One might be effective in one study. When it comes to reproducibility in other test and other study, it is not showing the similar effect. So one of the studies, few of the studies are showing yes, the results are reproducible, but they are not convincing enough to give them. Okay, they are not encouraging enough. So this is how these are some of the methods which helps in preventing the preeclampsia. Now let's get back to the most important part of our discussion, that is, how will you manage a case of preeclampsia and also eclampsia, or more precisely pregnancy induced hypertension. It can be anything, right? So I don't want to take this umbrella term, rather I'll say gestational hypertension. So normal gestational hypertension, okay, normal elevation of the baby more than 140/90, but nothing else, no problem, no proteinuria, nothing. So for them, the mild cases, not even mild cases of preeclampsia, for a normal pregnancy induced hypertension, that is gestational hypertension, usually drugs are not suggested because it's a normal physiological response. We do a serial monitoring. We manage them on an outpatient basis so that you can diagnose preeclampsia early. Okay, we increase the frequency of prenatal visits. We manage them on an outpatient basis. But whenever there is development of proteinuria or any during the detailed examination, daily weight determination, urine analysis, okay, if there is anything, if we do LFT, RFT and CBP, and if you see HELP syndrome kind of features, giddiness, headache, visual disturbances, any abnormal finding, we hospitalize them. Okay, so usually mild cases of gestational hypertension, we don't do anything, we just do a serial monitoring. But if there is any development of proteinuria, we admit them, we do a regular BP monitoring, we send all the investigations, we also evaluate the fetal well-being, the size of the fetus, because sometimes chronic hypertension is associated with IUGR, intrauterine growth restriction, and also we measure AFI pockets to check for oligo or polyhydramnios. And one of the important stuff is, let us say there is development of proteinuria which will diagnose preeclampsia. Now you have a preeclampsia, whether it's a mild, that is non-severe, or severe, you have to do this classification, and how it is done we have discussed in the early part of the discussion. So now let's say it's a non-severe, that is mild disease. So whatever it may be, we advise reduced physical activity. Reduced physical activity is not strict bed rest or absolute bed rest. Absolute bed rest is not needed, and it might increase the risk of development of DVT, deep vein thrombosis, and leading to embolism. So reduced physical activity throughout much of the day is more than enough. We advise ample protein and calorie intake, so there is no dietary restriction, and never force a sodium or fluid intake. Okay, it's not usually required. What is more important is reduction in the physical activity. So in these cases, if it is mild, if the condition is mild, you can manage them on a conservative basis. Wait for the labor to commence and deliver spontaneously. But in severe cases, we have to give neuroprophylaxis, that is anticonvulsant therapy with magnesium sulfate. We also need to give antihypertensive therapy in severe cases. Then it should be followed by the delivery. So in the next part of the discussion, you see, just I gave you a general guidelines. By this, if you are reaching this point in the video discussion, you already know how to differentiate non-severe from severe. So if it is mild, we do an expectant management or a conservative approach. I'll tell you how conservative approach is done and when to convert this conservative to serious one. And when it is converted to serious one, what are the principles of anticonvulsant therapy, antihypertensive therapy, and when to deliver, and what methods to be followed, what are the delivery methods which are available. So before going into that details, let me tell you one dictum. Whenever severe preeclampsia is diagnosed, you have to induce the labor, and the ideal way of delivery is vaginal delivery. It's ideal. But after induction, if the induction failed, because most of the times it will not succeed, or if any attempt is failed, then you have to choose cesarean delivery. So straight away, the choice of delivery, the method of delivery is not cesarean in preeclampsia, even it is severe. We can try a traditional vaginal delivery method. But because of the urgency, because of the complications, as I told you, it starts as a mild disease or a moderate disease, but very rapidly it progresses into a severe disease. So it will not allow time. So because of all these things, preeclamptic cases or severe preeclampsia, eclampsia cases are usually managed with the help of cesarean section. So what is this conservative management or expectant management? When to follow it? So all the guidelines are given here. Less than 23 weeks, if any mother is coming with severe, very severe preeclampsia, just terminate the pregnancy. But in between 24 to 34 weeks, if you see a case of severe preeclampsia, you can try a conservative approach, but most of the studies do not show an overwhelming benefit. Okay, so when you have a risk-benefit ratio, the dictum is, if there is preeclampsia, it is not good for mother. The goal or the purpose of this conservative or expectant management is only to allow the fetus to mature so that she can survive outside. But when it comes to the point of mother, it is always harmful. Delivering the baby is the only the cure for preeclampsia. But in 24 to 34 weeks, though the studies are not showing overwhelming benefits, you can still follow this conservative or expected management approach. So here, the same thing we are discussing. So in the question, if they say age is less than 34 weeks, even if it is equal to or more than 34 weeks, you have to write the management in lines of these paragraphs. That is, hospitalize, do systemic evaluation, detailed examination, weight determination, regular BP monitoring, LFT, assess the everything, and then deliver. Whether it's a cesarean or everything, you have to. But if it is less than 34 weeks, then you can follow this conservative management. Admit in the labor and delivery department, do some assessment. Always in severe preeclampsia, consider neuroprophylaxis with magnesium sulfate. Please don't see magnesium sulfate. Is it an antihypertensive or anticonvulsant? Which one it is? Magnesium sulfate is only anticonvulsant. It has no role in management of hypertension. What is that we usually give for management of hypertension? We give labetalol. Okay, labetalol IV or hydralazine IV, the second drug which can be given IV, or we can even give calcium channel blocker, which is oral. Okay, but neuroprophylaxis is usually given with anticonvulsant, that is magnesium sulfate. If there is, in severe preeclampsia, if there is a dangerous hypertension that is like more than 160/110, then you look for treating it with antihypertensives. So now you have decided to manage this patient conservatively. What are the contraindications? Even while you're managing, if there is a persistent symptom, if the severe hypertension is not responding to antihypertensive, eclampsia development, pulmonary edema development, HELP syndrome, if there is significant renal dysfunction and coagulopathy, if you see abruptio placenta, okay, in the pre-viable state, that is pre-viable is less than 23 weeks, right? It's not viable. None of the child survived for less than 23 weeks. And also if there is a fetal compromise. In all these scenarios, as you can see, these are the contraindications to the conservative management. If there is no contraindication, you can just observe it for a day or so, 24 to 28 hours. And yes, we give corticosteroids to allow for lung maturation because it helps in surfactant secretion. You have to do a frequent evaluation. You have to monitor urine output. Let me tell you, one of the very important prognostic sign is improved urinary output. Okay, it is a very good prognostic sign. And we have to evaluate the vitals. Daily laboratory evaluation should be done for HELP syndrome. So these are done. If the patient is doing well for next 24 hours with this, you have to continue this ongoing inpatient management. You have to daily assess the mother, serial lab evaluations to find out any risk, any progressing factor or severe factor. And if the conservative management is doing well and good, then deliver the baby at 34 weeks. But in chance, if the baby is developing any of the contraindications during the follow-up, you have to deliver the baby or terminate the baby there and then itself. Okay, so this is a management algorithm for suspected severe preeclampsia at less than 34 weeks. If it is more than 34 weeks, yes, you have to deliver, but you cannot just blindly deliver a baby, because if the BP is very high, okay, you have to treat the hypertension, right? Severe hypertension, and if you are doing a cesarean section, there will be profuse bleeding and it is not good for mother. How to control this high BP? As I told you, mild to moderate hypertension, except for few episodes, none of the studies have shown any benefit. Okay, so that's the reason we usually don't give this IV antihypertensive medication for 140/90 or 150/90 or 150/100. The goal is to lower the BP to below 160/110. That's it. So that's the reason if the BP is 180/120, 190/110, 160/110, then you should worry. So the three most commonly used drugs for the management of severe hypertension are, as I told you, hydralazine IV, please remember, labetalol IV, and also the nifedipine orally. I'll only give you one characteristic thing. Most commonly used drug, IV hydralazine, which is most commonly used drug. A drug with fewer side effects but efficacy similar to hydralazine, that is labetalol. Because labetalol has less side effects, you can give it. If you want to achieve a rapid response and if you want to give an oral drug, nifedipine, that is the calcium channel blocker, also works. I have given the dosages, just go through them. But most importantly, the maximum dose of labetalol, this is an MCQ. Maximum dose of labetalol per treatment cycle is 220 mg. That's it. More than 220 mg you cannot give. So labetalol have a dose restriction, but hydralazine works very well, which is most commonly used drug. You can choose any of this. So we're discussing the management of preeclampsia. In severe preeclampsia, you need to give an antihypertensive therapy, as just discussed. You also need to give an antiepileptic therapy. But as I told you, let's say the patient has already developed eclampsia. So this parameter comes into management of eclampsia. Please don't confuse. What I'm trying to convey here is, if you want to give an antiepileptic therapy, it can be given after seizures or before seizures. But there is a role for anti-epileptic therapy even before the onset of the seizure in preeclampsia, because after seizure means eclampsia. The patient has entered into the eclampsia, eclamptic fits. But before seizure, we call it as neuroprophylaxis. But for both of these, the drug of choice, the anti-epileptic of choice is magnesium sulfate. Why we are not giving valproate or phenytoin or fosphenytoin or benzodiazepines, barbiturates? Why we are not giving those? Because they all have a common side effects, because they are hypnotics. they cause respiratory depression. Okay, sorry, they also cause mental confusion and they lead to CNS depression, which is more appropriate. So because I'm striking off respiratory depression because magnesium sulfate has a side effect of respiratory depression because of high magnesium content or hypermagnesemia. That's the reason. So why we give magnesium sulfate instead of all the antiepileptics? Why magnesium sulfate is the antiepileptic of choice here? Because this causes this will not cause CNS depression. The other epileptic drugs, they cause CNS depression. So that's the advantage, as you can see. Magnesium sulfate is not given to treat hypertension, as I told you. Magnesium sulfate avoids producing CNS depression in either the mother or the infant. So that's the reason, both for the prophylaxis and also the management of seizure, the treatment of choice is magnesium sulfate. So what is the what we call eclampsia? If develops, you can straight away give. But when it comes to neuroprophylaxis, what is the timing of neuroprophylaxis? Seizures are more prone to develop in a case of preeclampsia, eclampsia, usually during labor and 24 hours postpartum. So just if the date has come, if the due date has come, EDD, within 24 hours before the delivery of every 1 day, you will be starting the treatment, and this dosages is continued even 24 hours after the postpartum. This is the best time to give. Let's say if this is a neuroprophylaxis, there is no question of differential diagnosis. But if you are writing answer for management of eclampsia, first and foremost thing is you have to say whether this epileptic fit is because of eclampsia. For that, you have to rule out in history. You have to ask for epilepsy. You have to ask for a physical history of any encephalitis or meningitis. You know the signs of meningism should be elicited. The signs of for the focal neurological deficit should be evaluated. CNS examination should be done. CT brain or MRI brains to be done to rule out brain tumor. You have to look for the raised IoT signs. You have to do an MRI of the brain to identify the neurocysticercosis, the epidemiological history. The place of residence is important to identify the cysticercosis. If there is amniotic fluid embolism, you have to identify it. If there is postdural puncture cephalgia, ruptured cerebral aneurysm, all can be diagnosed with the help of MRI. So after ruling out these all, so if there is a epileptic fit and there is no cause for it in a preeclamptic patient, then this is eclampsia. What do you do immediately? Don't just write the answer for management of eclampsia saying that you give anti-epileptic therapy. But immediate management is very important because we have seen many cases with a tongue bite. Because at the onset of seizures, generalized tonic-clonic seizures, at the time of clonicity, the teeth might bite the tongue. Normal seizure is fine, but here, along with the teeth bite, the patient might be having thrombocytopenia, which can lead to profuse bleeding. Okay, you have to protect her airway. You have to protect the patients from the tongue bite. Okay, so immediate management of a seizure, whatever we do for the management of seizure, all those precautions should be followed. Along with that, we have to manage the seizure. So how it is managed? First part is neuroprophylaxis. So what is the criteria for neuroprophylaxis? You can't just give away the magnesium sulfate to each and every woman who comes with preeclampsia. Okay, or each and every woman who comes with gestational hypertension. In a new onset proteinuric hypertension, any one of the following criteria is very important. So this is Parkland Hospital criteria. So only those women in according to 2013 task force recommendations, only these women who satisfy this criteria of Parkland Hospital criteria, they are given this neuroprophylaxis. The systolic BP, if it is more than 160, diastolic BP, if it is more than 110, proteinuria is not 1+, it is 2+ in the dipstick, serum creatinine elevated, platelet count low, elevation of the AST ALT not simple, but it should be 2 times above the upper limit. If there is a persistent headache or development of scotomas, if there is any liver tenderness, that is right upper quadrant pain, in all these cases they might go into complications. So then you have to start the magnesium sulfate neuroprophylaxis. So this magnesium sulfate neuroprophylaxis, or if it is given in eclampsia, how we give it? There are 2 methods for it. One is continuous IV infusion in a continuous mode. So there is no painful IM, because we all know this IM injection of max sulfate during your internship, if you have given it in labor room, this IM route of giving this max sulfate is painful thing. That's the reason we alternate in we give it in an alternate buttock every 4 hours. So that continuous IV infusion and IM injections both are equally efficacious. You can choose any of this, but because continuous IV infusion has an advantage of being less painful, most of the institutes, okay, they are using it. But in a country like India, during my practice, during my internship, we only used to give this IM. So this IM route is intermittent intramuscular injection route is Pritchard's regimen, because this is more important, this is more realistic for a country setup like India. I'll discuss this first. See, one of the disadvantages with continuous IV infusion is, in continuous IV infusion, you have to serially monitor the serum magnesium levels, which is not possible most of the times, because you are doing a treatment, you are sending it to lab, but the reports will come the next day. How can you serially monitor it? So it's not possible in a setup like us. So we still prefer Pritchard's regimen in India, which is given intermittently in intermittent intramuscular injections. So we have a loading dose and maintenance dose. This is very important even during MBBS theory and during internship and for exams, PG entrance exam. You have to remember the dosages. Please go through it. Okay, I'm not briefing it, but this parameter, this table is very important. And whenever you continue this loading and maintenance dose, the treatment is continued even like for 24 hours after the delivery or the last convulsion, whichever occurs later. And monitoring of the therapy is very important in these cases. There are 3 parameters which we usually monitor, very high yield viva question. That is respiratory rate, patellar reflexes and urine output. Respiratory rate should be maintained at least 16 per minute. What is the problem with hypermagnesemia? Respiratory depression. Whenever you see decreased respiratory rate, immediately you have to stop the max sulfate. You have to treat with either calcium gluconate or calcium chloride 1 gram IV, which will reverse either mild to moderate respiratory depression. And other thing is patellar reflexes. The reflexes should be present, but in hypermagnesemia there is loss of patellar reflexes, which usually occur at a serum magnesium level of 10 to 12, which is an important MCQ. Okay, but one more important is, it is the earliest indication of max sulfate toxicity. And parallelly, as I told you, one of the most important and high yield prognostic stuff is urine output measurement. While doing this Pritchard's regimen, urine output level should be maintained at least 30 ml per hour. Okay, so this is also very important to monitor the therapy of max sulfate for the signs of toxicity. Let me also tell you about the continuous IV infusion. It is almost universally administered IV, but in most units in Western countries, the IM route has been abandoned. 4 to 6 gram loading dose is given, diluted in 100 ml of IV fluid. So these values, please go through them. But here, for the monitoring of magnesium toxicity, we look for deep tendon reflexes and also we measure serum magnesium levels. Yes, we have discussed the management of eclampsia with regards to the anti-epileptic and antihypertensive therapy. Basically, the principle of management is simple. Whenever there is a convulsion, you have to do a differential diagnosis. You have to what we call basic management of any seizure patient. You have to control it with max sulfate. The same dosages are followed, IV or IM route. Okay, and at the same time, we also need to decrease the hypertension levels by giving antihypertensive medication. But very importantly, please avoid usage of diuretics in a case of management of either preeclampsia or eclampsia, unless there is an obvious pulmonary edema. Okay, because already we also need to limit IV fluid administration unless you see a fluid loss. So we have to avoid fluid retention in this. And delivery of the fetus should be achieved, okay, for remission of preeclampsia. This is another goal.